The next chapter that we'll be starting with is the hepatobillary system. There are set number of topics that you need to know, and I'll give you a quick overview of those. First, you need to know the normal hepatic lobule. You need to know the different bilirubin metabolic disorders, especially the congenital ones. You need to know the causes of cirrhosis with special emphasis on alcoholic liver disease, hemochromatosis, and Wilson's disease. And in the end, you need a wrap up of all the hepatic tumors. So we'll try to keep a 45-minute target and we'll finish off this chapter as quickly and effectively as possible. So let's get going with the hepatobiliary system. You know there's a hepatic lobule given in front of you. Let's label it. In the center, what will we have? Obviously, we will have the central vein, and in the periphery, we will have the portal triad. So these are these three ones. These are the portal triad. So center mein vein, periphery pe triad, and what do you have? These white color cords in between. These are going to be the cords of hepatocytes. These are referred to as the cords of hepatocytes, right? How do they get their blood supply? Of course, in the center, there must be some blood vessel. There must be some blood vessel which is giving all these cords of hepatocytes some kind of blood supply, and that is known as the sinusoids. So these are all the labeling things that you had to know. Now I have to ask you, where are Kupffer cells, where are Ito cells, and where are oval cells? These three cells are very important. So सबसे पहले please note, I am asking you what is Kupffer cells. Kupffer cell क्या होता है? Kupffer cell is the macrophage ना? Macrophage of the liver is known as Kupffer cell. So that is present somewhere here in the wall of the sinusoids. Kupffer cells are present in the walls of the sinusoids. Macrophage का location हो गया? Sorted. Now I want to ask you the next question. Where do you think is the presence of the very famous, the stellate or the Ito cell? So pehle to you will have to tell me what is space of Deci. That is the first thing that I want all of you to know. What is the space of Deci? तो ये जो space दिख रहा है मतलब between the sinusoid and the cords of hepatocytes, or between the sinusoids and the cords of hepatocytes, इन दोनों के बीच का जो space है, that is known as the space of Deci. What does space of Deci have? Number one, it has the very famous Ito cells, and number two, it is the space where amyloid gets deposited. Go back to your immunology chapter. The first space for amyloid deposition is the space of Deci. So two things, Ito cells are over here, the amyloid is going to deposit over here. So now if I ask you, what are Ito cells? Ito cells are also referred to as stellate cells. So Ito and stellate is going to be the same. Let me ask you one more diagram. So ye dekho, if they say in the exam that these are the hepatocytes, this is one labeling that is done, and next they say that this is the sinusoid. So if they ask you what is this that is present in the wall of the sinusoid, you will say, oh, this must be the Kupffer cells. Versus if they ask you what is this space between the hepatocytes and the sinusoids, this space ko kya kehte hain? You will say, oh, between the two, this is the space of Deci. So which cell must be there in the space of Deci? This must be the Ito or the stellate cell. So are they the same? Ito cell and stellate cell same hota hai? What did I teach you in the main videos? Ito cell and stellate cell is the same person. One is the proper name, one is the pet name. Okay, so what is it? Proper name, outside. People outside your house call you with that name, formal name. And one is your pet name. Pet name is in your house. In your house, you're only sleeping and eating and doing nothing. Hai na? So one is going to be the name where people call you, like we all call it Ito cell. Ito cell matlab it is only going to sleep and eat. All that it's doing is vitamin A storage. All that it's doing is sitting and eating vitamin A storage. The same Ito cell, if it gets activated, bahar chale jao, you will have to do a lot of work. The same Ito cell, if it gets activated, it is known as a stellate cell. What is a stellate cell doing? Stellate cell is going to do collagen production. Stellate cell shall do collagen production. So basically you are the same person, but one day before the exam you are super duper active, you are doing a lot of work, that is stellate cell, and 1 year before the exam you are just sitting and eating, that is Ito cell, that is vitamin A storage. But you are the same person na, to cell to wahi hai, but in different circumstance behaving differently. Ito cell when it is eating vitamin A, keeping all the vitamin A inside it, and stellate cell when it's producing all the activity wala, that is the collagen. Okay, so this is present in the space of Deci. What other space do we have? There is another space, guys, which is very famously known as the canals of Herring. What is the canals of Herring? Firstly, you will say that, ma'am, you are only focusing on hepatocyte. Matlab, these hepatocytes that you are talking about. But what about bile duct wala cells? What are bile duct wala cells? cholangiocytes. Why are you not focusing on the bile duct? How will the hepatocytes and the cholangiocytes interact with each other? Canals. So between the site and the site there are canals. Cholangiocyte and hepatocyte के बीच में canals of herring, and that is where the oval or the stem cell is present. Do you know stem cell of the liver? Stem cell of the liver is known as oval cell, and where is the stem cell hiding? It is hiding in these hidden canals of herring. So repeating, now I've got you 3 questions. Quickly answer. Where are Kupffer cells present? They are present in the wall of the sinusoids. Where are Ito cells and amyloid going to deposit? In the space of Deci. Where are oval or stem cells present? They are present in the canals of herring. Where are canals of herring? Between the two site and site, hepatocyte and cholangiocyte. So the normal is done. This is what the picture looks like. See, you have the central vein over here. And can you all see how these cords of hepatocytes are going out? These are all the cords of hepatocytes. This is how the liver microscopic examination looks like. Anatomy ho gaya. Now let me ask you physiology. Physiology matlab bilirubin. Before I start with hyperbilirubinemia, or in other words that is jaundice, I want to ask you one simple thing. What is the enzyme that you remember that causes conjugation? Do you remember which enzyme causes conjugation? UDP glucuronil transferase. For those who've not studied physiology abhi tak, this is very basic. Please do go ahead and study it. So UDP glucuronil transferase, that is what is going to cause the conjugation. Bilirubin conjugation by UGT. So now, if I say that someone is having hyperbilirubinemia, you will say either there is a problem that conjugation did not occur, unconjugated bilirubin is only increasing, or there is a conjugation that occurred, but after that the problem occurred, so conjugated bilirubin is increasing. So what are the two syndromes that you have for unconjugated hyperbilirubinemia? For unconjugated hyperbilirubinemia, we have Crigler-Najjar syndromes and Gilbert syndromes. And what are the two for conjugated? Conjugated ke liye we have Dubin-Johnson and Reuter. Confusion to hoga. Which syndromes come under unconjugated, which come under conjugated? So simple. When you make this list, under conjugated, I said Crigler-Najjar and Gilbert. Under conjugated, I said Dubin-Johnson and Reuter. So remember, doctors are always conjugated. Doctors are always united. Na? So doctors are always conjugated is how I have learnt it. So Dubin-Johnson and Reuter is always going to be conjugated. So coming back, moving to the individual details. I'm starting with unconjugated hyperbilirubinemia, Crigler-Najjar and Gilbert. Why do you think it is unconjugated? You will say, ma'am, that enzyme must be missing. UDP glucuronil transferase basically must be a problem. So, too much of problem, thoda kam problem, thoda kam problem. That is what it is. Crigler-Najjar type 1 is complete deficiency of UGT. This person has zero levels of UGT, no level of UGT, 0 level of UGT. So this patient is never going to survive. This is 100% fatal. It usually results in intrauterine death or stillbirth. This is not possible, not compatible with life, because this person, this child does not have any molecule of UDP glucuronil transferase. Crigler-Najjar type 2 is partial deficiency. Thoda hai, thoda missing hai. That is partial deficiency of UGT, so the person will survive. Maybe you can give some drug and that person will survive. So medicine question to you, what is the treatment that you give to this person? We give a drug called phenobarbital. Moving on, so phenobarbital hoga, so like say 50% is there, 50% is missing, so you will give phenobarbital, that 50% will start, you will increase the activity of UGT. That is what it does, it increases the UGT activity. Coming to the last one, and that is Gilbert syndrome. This is very mild deficiency, hardly any deficiency, very mild deficiency. This will manifest only in stress. This will manifest only in stress. Otherwise, patient is asymptomatic. Patient otherwise in day-to-day life is asymptomatic. Only when the patient has any fever or pregnancy or some chota-mota infection, then the disease will come up. Otherwise, the person is totally asymptomatic. So what did I tell you? Crigler-Najjar type 1, type 2 and Gilbert mein kya dekha? 100% deficiency, little bit deficiency and very little deficiency. Max, minimum, aise karo yaad, right? So when there is total deficiency, not compatible with life. Little deficiency, little thoda hai, thoda nahi hai, give a drug, patient will survive. And very mild deficiency to is more or less asymptomatic. Unconjugated is done. Crigler-Najjar and Gilbert is done. What about Dubin-Johnson and Reuter? Doctors are conjugated, na? Dubin-Johnson and Reuter. So you will say, ma'am, enzyme to theek hai, UGT is fine, conjugation has occurred. The problem is in the excretion. that bilirubin is not getting excreted further. So either this is going to be an MRP defect, Dubin-Johnson is an MRP defect, and rotor is an anion transporter defect. ये थोड़ा सा रट्टा that you will have to do. Okay, Dubin-Johnson is an MRP defect and rotor is an anion transporter defect. The question that comes is that which of them has a dark liver, or which of them has a dark pigmented liver, and that is Dubin-Johnson. So please remember D for Dubin-Johnson, D for dark pigmented liver. That is going to be seen, whereas in rotor there is no pigment. In rotor there is no pigment that you see. Now coming back, what is this pigment? Dubin-Johnson में जो dark pigment है, this pigment is known to be epinephrine. This pigment is known to be epinephrine. So let's repeat all of this once again. When I'm talking about Dubin-Johnson, so now because I just felt that कैसे रट्टा लगाओगे, I hate to say this sentence to someone that रट लो, बस ऐसे ही रट लो, and then to leave you guys on your own. Somewhere when I say that, a part of me has so much of guilt in it. So it's an impromptu mnemonic while recording this video. I hope it makes sense. So Dubin-Johnson, when I say Dubin-Johnson, it's reminding me of that Johnson and Johnson वाला company. तो Johnson and Johnson company का powders आता है ना, Johnson's baby powder, है ना? तो Johnson's baby powder is being sold at MRP, the retail price. So MRP defect is Johnson baby powder wala. Whereas when I'm talking about rotor, is it sounding like transporter? Rotor is sounding like transporter, na? So that is a transporter defect. A very impromptu mnemonic. I hope right now have made it. I hope it makes sense. Johnson's के लिए it is MRP defect. Johnson's company MRP पे sell करेगा, and rotor is going to be transporter defect. ठीक है? And this तो we already know which of them has a dark pigmented liver. Dark pigmented liver is seen in Dubin-Johnson, and the pigment is epinephrine. So we are done with the two syndromes. Now the question is, all of these are gonna be autosomal recessive. Crigler-Najjar, Gilbert, Dubin-Johnson, rotor, sub autosomal recessive? Nahin. Please remember, Crigler-Najjar type 2 is autosomal dominant. How have I learnt it? Autosomal dominant. Dominant sounds like do. So do wala is dominant. So Crigler-Najjar type 2 is do na. Type 2 do. So do is dominant. All the others are autosomal recessive. One advanced information that I want to give to you guys, especially if you're going for INICT, rare varieties of Gilbert. Rarely or rare varieties of Gilbert can also act like a Girgit. Means it can also sometimes it can be autosomal dominant also. So repeating, all of them are autosomal recessive only, but Crigler-Najjar type 2 is do dominant, and Gilbert can sometimes be a Girgit. Girgit is chameleon, changes color na. So sometimes it can be a Girgit and sometimes it can become autosomal dominant, but usually if they ask you which is that one which is autosomal dominant, so Crigler-Najjar type 2 matlab do, that is going to be dominant. I hope this is okay with everyone. Hyperbilirubinemia is done. We can move forward. Next, we are going to go on to the another set of very important disorders which will get you a lot of questions, and those are going to be cirrhosis of the liver. So pehle to you have to know what is cirrhosis. Next, I have to tell you all the cirrhosis ke causes, and in that the chapter will only end. When we are talking about cirrhosis, this is nothing but nodule formation. Nodules are going to be formed. These nodules can be less than 3 mm or they can be more than 3 mm. If they are less than 3 mm, we call it micronodular cirrhosis. We call it micronodular cirrhosis. And if they are more than 3 mm, then we call it macronodular cirrhosis. So repeating, micro versus macro ka cutoff is going to be 3 mm. Let me show you. Have a look at this. When you're seeing very chota, tiny dots, these kind of nodules, micronodular, less than 3 mm is the cutoff. And where do you see it? You see it in hemochromatosis, which is iron overload. You see it in Indian childhood cirrhosis. You see it in PBC, that is primary biliary cholangitis. Primary biliary cholangitis. And alcoholic liver disease तो can show you micro, macro, everything. तो alcohol तो I'm not including. Alcohol में सब दिखता है. These three you have to know. Indian childhood cirrhosis. What did I say? Indian childhood. Childhood मतलब छोटा बच्चा. तो छोटा बच्चा, छोटा nodules. छोटा बच्चा, छोटा nodules. तो Indian childhood cirrhosis is gonna show you small nodules. Hemochromatosis. Again, hemochromatosis has C in it. Everywhere C वाला ना, I'm remembering it as child. It's not happening in children. but it means it's chota chota, small small. So all the CC ones are going to be chota chota nodules. They are going to be chota chota nodules, means less than 3 mm. Whereas where do you see more than 3 mm? More than 3 mm means very very big. You can see that they are very very big. Very very big are seen in very very viral and very very Wilson. Easy ho gaya na? So simple. When I say chota chota nodules, so all the CC things are coming. Indian childhood cirrhosis, hemochromatosis, primary biliary cholangitis or cirrhosis. So all CCC ones are chota chota nodules. Whereas very very big nodules, how did I learn? Very very big nodules are viral hepatitis and Wilson's. Viral hepatitis and Wilson's. And what did I tell you about alcoholic liver disease? वो micro है, macro है. Alcohol is तो loved by all, seen in all. So alcoholic liver disease is going to show you micro and going to show you macro. So you understood what cirrhosis is. Nodule bana, but that nodule is going to be divided by what? Nodule is divided by fibrosis. So now the question is, this fibrosis is nothing but collagen. So two questions coming up your way. Which type of collagen is going to be there in cirrhosis of the liver? Answer is collagen type 1 and 3. This is a PYQ. Please repeat with me. Which collagens are deposited in cirrhosis? Collagen type 1 and 3. Second question is, the source of this collagen, that I've told you. Remember one cell that was present in the space of Deci? When it is sleeping, you call it itocell. It is only sitting and storing vitamin A. But when it gets active, you call it the stellate cell. And the stellate cell is present in the space of Deci. Yaad aa gaya, everyone? So this is the story of cirrhosis that you had to know. There are nodules, small, big. You've done the story. There's fibrosis, that is collagen type 1 and 3. And you have the source of those, that is going to be the stellate cell. So what are the causes of this cirrhosis? Please note, the causes of cirrhosis are A, B, C, D, E. I've tried to keep it a little bit in alphabetical order. So please note, alcoholic liver disease, autoimmune hepatitis. So I'm starting from this, and when I'll talk about alcoholic liver disease, na, everything will go for cryptogenic. Cryptogenic matlab non-alcoholic liver disease. Cryptogenic is nothing but non-alcoholic. So whatever I'll tell you for alcohol, copy paste, that is going to be for non-alcoholic also. So what is it? And I'll keep coming back to this because you know one by one I'm going to quickly talk about all of these points. So first and foremost, when I talk about alcoholic liver disease, obviously it is to do with alcohol. So cheers to that, but not cheers for the patient, because what are the problems that his liver is going to come up with? The first thing that happens in the liver is going to be steatosis. When I say steatosis, it means fatty liver, hai na? It means fatty liver. So I'll show you pictures. Now all of you will ask me that, ma'am, theek hai, fatty liver jab hota hai, what kind of fat vesicles are there? Are there chota fat vesicles called microvesicular fatty liver? Or there are macrovesicular? What do I say? Alcohol is loved by everyone, is going to show everything. It will show you chota vesicles also. It will show you big vesicles. Please note, microvesicular fatty liver and macrovesicular fatty liver is not the same as micronodular cirrhosis and macronodular cirrhosis. Please note that difference. Many students get confused. Micronodule and macronodule is what you're seeing with your eyes. The nodule, the size less than 3 mm, more than 3 mm. It's the nodular thing. Whereas when I'm talking about microvesicular and macrovesicular, it's what you're seeing under the microscope. This is what you see when you start seeing chota white spaces, tiny fat vacuoles. Those are microvesicular fatty liver. When you start seeing big fat spaces, you will call it macrovesicular fatty liver. So confuse mat hona. Macro nodular is different. Macro vesicular is different. So where do you see chota fatty liver? Tiny droplets of fat. So you have to think of tiny children. You have to think of Ray's syndrome. I hope everyone knows Ray's syndrome that happens in children after consuming aspirin. Na? You studied this in pediatrics. Ray's syndrome is after aspirin consumption. Chota bachcha mein. To chota bacha, chota vesicle. Chota bacha karne ka procedure is pregnancy. So in fatty liver of pregnancy, in which the mother is going to have a chota bacha, then also chota vesicles, microvesicular. And the mother only in pregnancy can have HELP syndrome. That is also the journey of chota bacha. So either a chota bacha or the journey of chota bacha is going to result in chota vesicles. So Ray's syndrome in kids, fatty liver of pregnancy, HELP syndrome in pregnancy, all of these called small vesicles. Whereas everything else mentioned, that is obesity or all metabolic things, obesity, diabetes mellitus, starvation, total parenteral nutrition or hepatitis C. These are gonna be macrovesicular steatosis. So please remember, the chota bacha wala things are microvesicular. All the things to do with either starvation, not eating at all, or obesity, eating too much, or total parenteral nutrition, or diabetes, all metabolic things. And hepatitis C is going to result in macrovesicular steatosis. But why am I studying it over here? Alcohol ki wajah se. But alcohol to shows you everything. Na? Alcohol loved by all, going to show you all. Microvesicular and macrovesicular steatosis is seen. So when someone starts consuming alcohol, the first stage he has is fatty liver. After that, few more years of him consuming alcohol, he will land up with steatohepatitis. Do you know how does steatohepatitis look like under the microscope? It shows you two very important things. It shows you the mammary hyaline bodies. It shows you chicken wire fibrosis. Ye dekho. It shows you these pink color structures called mammary hyaline bodies. Mammary hyaline bodies are something which are, they ask you the composition. Composition is cytokeratin 8 and 18. Composition is cytokeratin 8 and 18, and these pink color bodies are mammary hyaline bodies. Okay? Other than that, we also see chicken wire fibrosis. Can you see these blue color lines? How like a chicken wire, chicken fence, so that the chicken don't run away. Same way, like the wire and the fence, there is a blue line that is going throughout. So chicken wire fibrosis is noted. Please note, mammary hyaline bodies and chicken wire fibrosis are seen in a case of steatohepatitis. Coming to the third one, finally, if the person still keeps consuming alcohol, cirrhosis, and cirrhosis ke baad bhi nahi ruka, then finally there is going to be scar. The liver will go away. The liver is going to convert into a chota sa scar, and that is known as Lennox cirrhosis. That is known as Lennox cirrhosis. Repeating once again, what is the sequelae? The first one, steatosis. That is going to have chota, big, all sorts of vesicles of fat. Then steatohepatitis. That is going to have two things. Mammary hyaline bodies made up of cytokeratin 8 and 18, and chicken wire fibrosis. Finally, patient lands up with cirrhosis, scar banega, and of course that patient is going to die. It's going to be a fatal situation. So whatever you had said for alcoholic liver disease, the same sequel goes on for non-alcoholic liver disease. Matlab, even in non-alcoholic liver disease, first the patient has fatty liver, then the patient has steatohepatitis with the same kind of mammary hyaline bodies, and then the patient has cirrhosis. So one professor of mine used to say that when all of this has to anyway happen with alcohol and even without alcohol, then might as well drink alcohol. But all jokes apart, not promoting anything, but yeah, you at least know that whether it is with alcohol or without alcohol, the series of events is going to be the same. So now, when alcohol was being consumed, reason was alcohol. When alcohol is not being consumed, then what is the reason? This is seen because of metabolic problems like obesity, hypertension, triglycerides, cholesterol. All of these metabolic things are going to result in this fatty liver. Okay, all of this is done. We can move on to the next one, that is AIH, autoimmune hepatitis. There is one very famous thing, especially autoimmune hepatitis associated with drugs. Remember, autoimmune hepatitis shows you three very important pictures. Now, for the FMG students, this is not important at all. For NEET PG and INI aspirants, it is important. When we talk about autoimmune hepatitis, especially please remember, there is something called autoimmune hepatitis type 2, in which this can be associated with drug-induced. And drug-induced is basically going to be what? It is going to be a very funny story coming to your way. So, anti-LKM2 antibodies are responsible for autoimmune hepatitis. So, drug-induced autoimmune hepatitis ke liye anti-LKM2. So, how have I learnt it? Drugs. So they will give you examples. Drug-induced autoimmune hepatitis is to do with anti-LKM1, 2, 3 or other antibodies. You will say it is drugs though. That is, drugs, anti-LKM2 antibodies cause it. And what is autoimmune hepatitis going to result in? Three things. Firstly, autoimmune hepatitis, itis, inflammation. Lots of inflammation is seen. But where? It's at an interface. You say there is interface hepatitis. We notice interface hepatitis. Other than that, can you see some chota cells are being eaten up? What is that situation which I've taught you in the second chapter also? Emperipolesis is noted. Emperipolesis. And lastly, you will see that there's a cells, otherwise I used to say cells are in cords, liver cells are in cords. Now I'm saying liver cells are making a rose. So can I say hepatic rosettes are seen? Can we say hepatic rosettes are going to be Noted. So repeat, in autoimmune hepatitis, I see interface hepatitis, I see emperipolesis where cells are being eaten up, and I see hepatic rosettes. And one of the causes of autoimmune hepatitis is drug-induced, which is anti-LKM2 antibodies. Done with this as well. Moving back, so we are done with almost A to sare ho gaye, alcoholic liver disease, autoimmune hepatitis. C is done, cryptogenic, which is non-alcoholic liver disease. D is also done, that is drug-induced because it is anti-LKM2 antibodies showing you the same autoimmune hepatitis. We are left with B, that is biliary diseases. Now, when I say biliary diseases, they are going to be of two types, and that is the primary biliary cholangitis and primary sclerosing cholangitis. So, like I said, biliary diseases hai na, so they are problems in the bile duct. Kaun sa wala bile duct? Intrahepatic bile duct or extrahepatic bile duct. So please note that because in primary biliary, I can only see eyes. See the way you write biliary, so biliary mein I can only see eyes. So which hepatic bile duct will be affected? Only eye wala. Intrahepatic bile duct is affected. Whereas in primary sclerosing word agar likhe, so I can see both E and I getting affected. Matlab both extra and intrahepatic bile ducts getting affected. Lives become easier, na? Repeating, in biliary cholangitis, only intrahepatic bile ducts are affected. In sclerosing cholangitis, intra and extrahepatic bile ducts are being affected. And please note, why are they getting affected? So, before I come to the picture, you must know their underlying pathophysiology. So, remember, which is the one that you see in around 50 years of age? You will say, ma'am, bada, biliary is bada, and sclerosing is seen in chota, smaller, 30s. So simple, biliary is seen in bada people, 50-year people. Sclerosing cholangitis are seen in smaller, that is 30-year-old people. Why? Antibodies. Biliary cholangitis is seen in amma and anna. Amma and anna means anti-mitochondrial antibody, anti-nuclear antibody, whereas sclerosing cholangitis is seen in P-ANCA antibody. So now tell me, when I said primary biliary cholangitis is seen with anti-mitochondrial and anti-nuclear, amma and anna, amma is reminding you of females and P-ANCA is reminding you of papa. So amma is mama and P-ANCA is papa. So simple, amma wala is going to be more common in females and primary sclerosing cholangitis is going to be more common in males. Next, primary biliary cholangitis is associated with Sjogren's syndrome. It is associated with Sjogren's syndrome, or basically the concept is that it is associated with other autoimmune disorders. Whereas primary sclerosing cholangitis, because it is to do with P-ANCA, we know P-ANCA is also positive in what? P-ANCA is also positive in ulcerative colitis. तो अभी repeat, primary biliary cholangitis बड़ा लोगों में 50-year-old, sclerosing small लोगों में 30-year-old. Biliary बड़ा कौन? Amma and Anna are very big, so AMA and ANA are the antibodies, and Amma reminds me of females, so this is more common in females. Sclerosing cholangitis seen with P-ANCA antibody. P-ANCA reminds me of Papa, more common in males and associated with ulcerative colitis. ये हो गया. Then I've studied which is intrahepatic, which is both intra and extrahepatic. Now two things, radiology and microscopy. Radiologically and microscopically, it is only PSC that shows you changes. Primary sclerosing cholangitis shows you pruning of the bile ducts. When I say pruning of the bile ducts, pruning of the trees hota na, look at this, the trees have been cut, the branches have been cut. So same way, bile duct ka, can you see, it looks as if the branches has been cut. So primary sclerosing cholangitis shows you pruning of the bile ducts. Similarly, primary sclerosing cholangitis shows you onion skinning. Microscopically kya dikh raha hai? You see onion skinning of the bile duct. There is onion skinning of the bile duct. So I realized in primary sclerosing cholangitis only radiology is a problem and pathology is a problem. Primary biliary, amma anna are sorted. Amma anna wala biliary cholangitis, radiology no changes, pathology no changes. This primary sclerosing cholangitis is the one which is problematic. Radiology shows you pruning of the bile ducts and pathology shows you onion skinning of the bile ducts. So with that, your biliary diseases also come to an end. ABCD ho gaya. What do we move on to next? We move on to the enzyme deficiency, that is alpha-1 antitrypsin deficiency, and then we'll move further to the two overload conditions. When I talk about alpha-1 antitrypsin deficiency, there is one very important one flashcard that I have got for you which should sort it. So सबसे पहले, if I just ask you a simple question, tell me about alpha 1 antitrypsin, normal alpha 1 antitrypsin. कौन से क्रोमोसोम पे होता है? Very important question. Chromosome 14, and this is an autosomal recessive inheritance. The genotype says that if I have a person who is PIMM का genetics, MM मतलब normal. If someone's genetics is PIMM, M and N same लगता है ना, तो that person is normal. If someone is PIZZ, that person has the disease. Why have I written disease with this spelling? Because disease में ZZ आ रहा है, तो disease is going to be PIZZ. M is going to be normal, ZZ is going to be disease, and MZ is going to be carrier. So if both are present, this means the person is a carrier. हो गया simple. If someone has PIMM, that person is normal genetics. PIZZ means that person has the disease, alpha 1 antitrypsin deficiency, and MZ matlab the person is carrier. So now let's consider someone has alpha 1 antitrypsin deficiency. What are the organs that are going to get affected? The organs are going to be L and L, lung and liver. Lung and liver में, liver तो I am studying, it is going to result in cirrhosis, and lungs में there is going to be pan-acinar emphysema. Lungs में there is going to be pan-acinar emphysema, very important. So this is something you will study in medicine also. Lungs and liver are affected in alpha 1 antitrypsin deficiency. Many students learn it as LAL, that alpha 1 antitrypsin deficiency mein lung and liver is affected. Lung shows you pan-acinar emphysema, liver shows you cirrhosis. Finally, how are you going to do the diagnosis? You will have to do a stain. Name of the stain, PAS positive diastase resistant. Always remember, PAS matlab pink color. It is PAS positive diastase resistant. This is your flashcard for the enzyme disorders, that is alpha 1 antitrypsin deficiency, with which you have finished. Please note, you have finished your enzyme deficiency, and now I'm going to take you to the last two things, which is hemochromatosis and Wilson's. Iron overload, copper overload. Khatam. When I talk about iron overload, hemochromatosis, as all of you can see, iron overload is going to happen. What are the genetic causes and what are the acquired causes? Genetic causes में either there is a problem in the HFE gene on chromosome 6, तो HFE तो is telling me iron वाला gene है, or it is HJV gene, that is HJV actually stands for hemojuvelin. ठीक है, it stands for hemojuvelin, but can I rename it as juvenile? Because this is gonna cause juvenile hemochromatosis. This is gonna cause बच्चों वाला hemochromatosis, juvenile. So I have learned juvelin causes juvenile. हो गया ना simple? HFE will always be iron, Fe for iron, so HFE is causing hemochromatosis. HJV for juvelin, that is going to cause juvenile hemochromatosis. These were all genetic causes. What about acquired causes? Lots and lots of blood transfusion. Name me one situation in hematology where the patient needs a blood transfusion every 2 weeks. For example, it's a case of thalassemia. If it's a case of thalassemia, lots and lots of blood transfusions will be needed. Automatically, the patient is going to have an iron overload. Now, what are the clinical aspects? What iron to ho gaya? Iron will go and sit where all? You will say, ma'am, abhi to you are reading the chapter of liver. So iron will go and sit in the liver, and of course it will cause cirrhosis of the liver. But other than that, iron will also go and sit in the pancreas, and iron will also go and sit in the skin. So skin में क्या होगा? Skin में there is going to be a bronze color, and pancreas में क्या होगा? Diabetes. So what is the other name of hemochromatosis? Hemochromatosis is also known as bronze diabetes. So now you should know bronze because of skin problem, skin pigmentation, and diabetes because of pancreas. Finally, how will you treat the patient? You will say, ma'am, iron nikalo. If you want to treat the patient, iron nikalo. How do I take the iron out? Take some blood out. If you take the blood out, iron will also come out. So the treatment of choice is phlebotomy. But you'll say, ma'am, ये तो invasive हो गया ना. How can you always keep taking blood out? Can't you give any drug, some treatment in the form of a drug? So the drug of choice is going to be iron chelation. Can you name any iron chelation coming to your mind when it comes to pharmacology? What is it? Desferrioxamine. Desferrioxamine is the iron chelator that you are going to consider. So repeating once again, what is the treatment of choice? Blood nikalna, but that's not practical always. So the drug that you can give is desferrioxamine, which is an iron chelator. One more question I had, which I don't want to ask you because I've asked you a million times, is what is the stain for iron? Only for your reference I've got you, this pearls or Prussian blue is the stain for iron. ये बहुत बार पढ़ा है हमने. So iron overload is sorted. Now I can ask you the last one, and that is the copper overload. So what is it about copper overload that you need to be knowing? It is Wilson's disease. Iska genetics has been asked a lot of times. ATP7B gene mutation. Iska genetics is ATP7B gene mutation, and the copper is going to go and sit where all? Number one, the liver, because chapter is of the liver. So cirrhosis karayega. Next, it can go and sit in the eyes, and in the eyes, as all of you can see, a ring that is forming over here, that is the Kayser-Fleischer ring. Kayser-Fleischer ring, guys, is in which layer of the cornea? It's in the Descemet membrane of the cornea. It's gonna occur in the Descemet membrane of the cornea. It's a very, very famous question in ophthalmology. And finally, this can also go and sit in the brain. It can go and sit in the brain, it can go and sit in the basal ganglia, the putamen, yes. So remember, the liver, तो of course liver का chapter है, eyes में KF ring होगा, and brain में also it can go and sit, that is Wilson's disease. Can you give any copper chelator for this? Because it's to do with copper increase, of course the treatment is going to be the copper chelator, trientine. Trientine is definitely a drug that you can give for copper chelation. So yes, that wraps up Wilson's disease also. The overloads are done. Basically, all your causes of cirrhosis were done. And in that process, we realized that your entire chapter is only done. Hepatitis, I'm not including over here, guys, for obvious reasons, because microbiology mein hepatitis is like never ending. So what one or two slides can I show you over here makes no sense. But other than that, everything in cirrhosis we have finished. The last part that you have to know in liver is going to be the hepatic tumors, and in the rapid review I'm going to focus majorly on the famous hepatocellular carcinoma. Just one word of advice, not for the FMG students but for the NEET and the INI, especially for the INI students, even for NEET. When you read liver, read this rapid review. If time permits, 5 minutes also if it permits, do go back to the main course and read hepatic adenomas. एक table था which I don't want to include because it's a little higher end information, which I don't want to include right now because it's a rapid review. I want to focus on the most high yielding points, but if you want little better marks, इतना पढ़ा है तो थोड़ा और, and that is, do go back to the main videos and refer to hepatic adenoma, that is Bordeaux's classification. Is going to take 5-10 minutes of your life, but it will give you that extra edge. After that you will not get any question of liver wrong. Okay, I'm not including that in RR, but I couldn't skip it, so I had to give you that word of caution. Yeah, what my concern is definitely going to be on the main hepatocellular carcinoma. So 5 minutes about that. When we say hepatocellular carcinoma, ek to classical wala, which happens in almost whenever someone has HCC, it's usually of this type. One is little variant, little different type of hepatocellular carcinoma known as fibrolamellar HCC. So think logically. Tell me, what is the age? You say usually hepatocellular carcinomas occurs in 40s and 50s, old age wala hai, and the prognosis is very, very bad. Very, very bad prognosis. People with liver cancer have bad prognosis, and why do they have it? Because they have either suffered from some hepatitis B, hepatitis C, so those kind of conditions are there. That is why they ended up having liver cancer. If you have seen people around you with liver cancer, have you seen more of males or females? I'm sure you've seen more of males. So gender wise, because they say males have more alcohol, although ऐसा कुछ नहीं है, but males have more alcohol, so males have greater chances of liver cancer than females. So till now in India at least, males are more commonly affected. Ab everything about this is gonna become opposite. Fibrolamellar says, I am not gonna occur in 40s, I am gonna occur in 19-20-year-old kids. Kids only, I would say. For a liver cancer, 19 is no age. Also, this is nothing to do with hepatitis. You'll say, okay, when it is not because of hepatitis, then what is it because of? It is chromosome 19. So I have learned 19-19. 19-19 matlab 19 years ke age pe hoga, chromosome 19 will get deleted. How simple. The prognosis is good. God said that I can't be that mean that a 19-year-old is having cancer and I make him die. So the prognosis is overall good. Now they ask you, is there any male female? नहीं, इसमें कुछ नहीं है, male female preponderance नहीं है, it's all equality, gender equality. ठीक है, so both of them can have it. So remember, classical occurs in 40s, fibrolamellar in 90s. Classical is more in males and associated with hepatitis. This is no gender problem, no hepatitis problem. It is a 19-year-old person with a 19 chromosome deletion. There is going to be bad prognosis for liver cancer, but a good prognosis for fibrolamellar cancer. Next, what is the tumor marker? I think everyone knows. Tumor marker for classical is alpha fetoprotein, but for fibrolamellar, alpha fetoprotein levels are totally normal. Hepatocellular carcinoma mein to alpha fetoproteins used to spike up too much, but fibrolamellar says nahi, alpha fetoproteins are going to be normal. Because 19 years की age पर with a 19 chromosome deletion, thoda to tension hoga. 19, teenage is the age of tension about your career and studies, na? So kya tension hoga? Neurotensin. What is the tumor marker? The tumor marker is gonna be neurotensin. How does it spread? All hepatocellular carcinomas, they have hematogenous spread, whereas fibrolamellar has lymphatic spread. Fibrolamellar carcinoma has lymphatic spread. So repeating, remember, this is where you will catch it. You will have a 19-year-old person whose alpha fetoprotein levels are totally normal and neurotensin levels are very, very high. You know you're talking about fibrolamellar carcinoma. Well, that is it about HCC that you have to know. A very, very important table. Two more tables I want to tell you for the Central Institute exam students. Is there any new tumor marker for hepatocellular carcinoma that has come? Yes. So HepPAR to is telling me hepatic. HepPAR 1 and 3. So arginase 3 and glypican 3. These are new tumor markers for hepatocellular. HepPAR 1, arginase 3, glypican 3. The last table that I wanted to tell you, because you have read everything now, you need to know what are all the situations in the body where you see Mallory-Hylene bodies. Pura liver ka chapter ho gaya. Now in the end I want to tell you where all do you see Mallory-Hylene or Mallory-Denk bodies. So do you remember the picture of the Mallory-Hylene bodies, these pink color structures? I told you what are they made up of. They are made up of cytokeratin 8 and 18. So their mnemonic is New Indian Watch. Everything that you studied now, you will say that shows Mallory-Hylene bodies. So New Indian mein N for non-alcoholic and alcoholic liver disease. Both show you Mallory-Hylene bodies. New Indian, Indian for Indian childhood cirrhosis. That also shows you Mallory-Hylene bodies. What is Watch? W for Wilson's disease. A se kya pada tha? Alpha-1 antitrypsin deficiency. T se we study tumors right now like HCC. C for cholestasis. And H for not hemochromatosis. Many people believe कि अच्छा W से copper overload था तो H से iron overload hoga. No, it is hepatic or biliary diseases, because please remember that this is not seen in hemochromatosis. It is not seen in hemochromatosis. That is very important. So remember, non-alcoholic and alcoholic liver disease, Indian childhood cirrhosis, Wilson's, alpha-1 antitrypsin, tumors, cholestasis, and hepatic or primary biliary diseases. Primary biliary diseases, even secondary biliary diseases do not show Mallory-Hylene bodies. Only primary biliary diseases show you. So this New Indian Watch mnemonic is very, very important. These were the last two things that I wanted to tell you. The composition and the causes of Mallory-Hylene or Mallory-Denk bodies. The last slide is the most important. You're going to get it in a lot of places as you go ahead and solve questions. With which we wrap up our discussion of liver pathology. Let's begin with the next chapter, rapid review, and that is the renal pathology. Well, you all know it's a very, very important chapter when it comes not only to path, but a lot of questions that come in medicine as well as the tumors are covered in surgery also. So let's get going. I've divided this into 4 parts. First, we'll do the image fest. Next, we'll do nephritic syndromes, then nephrotic syndromes, and we'll wrap it up with renal tumors. So that's the entire plan of the renal pathology. Let's try to concise it. Quickly do it in as short a time as possible. So let's get going. The first thing that you have to know, the functional unit of a kidney, that is a glomerulus. And we all know that glomerulus is the one where all the filtration is occurring. So we have to know what is the filtration membrane, what is it made up of, where is all the urine formed. So you can see a black and white picture over here which belongs to the electron microscopic analysis, right? And what you see on the inner aspect, that is going to be The capillaries. So look at these red color capillaries. In capillaries ka lining. What is lining of the capillaries? It is endothelium. So what you have on one side is the capillary endothelium. Then over here you can see this blue color layer, and what is this? Bowman's capsule. Do you want to look at this under the microscope? This is the Bowman's capsule. How is it looking like? The Bowman's capsule is having these feet. It is having these podocytes. So please note, the Bowman's capsule is having podocytes, and which layer of the Bowman's capsule is it? It is the visceral layer of the Bowman's capsule. It is the visceral layer of the Bowman's capsule. So here we've got two layers in our filtration membrane. The red color layer is the capillary endothelium. Then the visceral Bowman's capsule is going to have these feet or podocytes, and what is in between them? Every cell of the body has a basement membrane. So what I have in between these two is going to be the glomerular basement membrane. So I realize that a filtration membrane is made up of three things. Number one, it is made up of the capillary endothelium, that is on the innermost aspect. Then you have on the outermost aspect the visceral layer of the Bowman's capsule, so we'll call it visceral epithelium. And in between the two you have the basement membrane. So a filtration membrane has three layers, and that is where your urine is filtered. Now we are going to start with an image fest where I'm going to show you all the gross appearances that you get in the exam. This is a 3-time repeat and NEET PG which you have to know, and that is putty kidney. So putty kidney, as the way you say T, it has too many T's. So putty kidney is nothing but TB of the kidney, which you can see radiologically over here as the calcification. And grossly, I think everyone knows kidney, TB matlab which necrosis? It's always going to be caseous necrosis. So what is going to be the urine finding that you will have? This will always be a case of sterile pyuria. This is always going to be a case of sterile pyuria. This means pus cells are there, pyuria, pus cells to hai, but the organism, the bacteria will not be seen, sterile. So that is what you have, always a history of sterile pyuria. With this picture will be given. It's a case of putty kidney that you see in TB. Next you have two appearances more. There is leather grain kidney and flea bitten kidney. Leather grain matlab aise ... Where do you see leather grain kidney? You see it in a case of benign hypertension. Leather grain kidney is seen in benign hypertension. And then what do you see in flea bitten? Flea bitten mein can you see flea, as if you know some flea has bitten you. So that is going to result in all red color wale dots, right? Red color dots means what? Pinpoint hemorrhages. And that is flea bitten kidney, and that obviously then you will see in malignant hypertension. So simple, if they give you a case of benign hypertension mein I will mark the leather grain kidney. Malignant hypertension mein I am going to mark the flea bitten kidney. But remember, flea bitten kidney is seen in a lot of other things which I'm going to tell you. So we hate PSM. No one tells the PSM educator this, I hope. But flea bitten kidney mein we hate PSM means where all do you see it? V for Wegener's granulomatosis. There is a disease called Wegener's granulomatosis. H for two things. HSP, that is Hinox-Schondlen purpura, and HUS-TTP. They also show you flea bitten kidney. P again for two things. PSGN, post-streptococcal glomerulonephritis, and polyarthritis nodosa. S again for two things. There is SLE and subacute bacterial endocarditis. And finally M. What is M? M is going to be for malignant hypertension. So repeating once again, Wegener's granulomatosis, HUS-TTP, and obviously a case of HSP, PSGN and PAN, SLE and SABI, and malignant hypertension. So benign hypertension, leather grain, malignant hypertension, flea bitten. Sorted? Next, the one that you've already studied in the immunology chapter earlier, waxy kidney. Waxy kidney is seen in a case of what? It is seen in a case of amyloidosis. So that is where you get to see the waxy kidney appearance. Coming to the next one. These are actually not gross findings but very important for microscopic findings. That is a case of chronic pyelonephritis. I hope you remember chronic. Chronic matlab chronic inflammation, itis, inflammation. But inflammation of where? Pyelo. It's inflammation of tubules. That is what is chronic pyelonephritis, and one of the most common causes is bacterial, that is E. coli. Urinary tract infection ke baad, basically it's a complication of a UTI. So if it's inflammation, it has to do with the bacteria, and that is going to be E. coli, right? What do you see? What is the picture that you get? The very classical picture. You get to see these tubule ka problem hai na. So you will see a picture of tubules. What is the picture of tubules? So there are tubules which have pink material. So if I say these are the tubules and I am saying there is pink material present inside them, this is known as thyroidization of the tubules. Because it's looking, aisa koi thyroid has not come in over here, okay? It's just looking, because of this pink material, it's looking like colloid and thyroid. So you see thyroidization of the tubules, that is what you notice in chronic pyelonephritis. Next question, chronic, which inflammation? So socho, you'll say, ma'am, chronic inflammation, matlab I'm going to see the presence of lymphocytes. Chronic inflammation में lymphocytes. So all the remaining ... that you're seeing apart from it, ये जितना भी blue color ... that you're seeing, these are all going to be the lymphocytes. So you'll say fine, it's a chronic inflammation, lymphocytes, it's a pyelo मतलब tubule problem मतलब glomerulus बिल्कुल ठीक, tubule problem, it's the glomerulus is बिल्कुल fine. So they will ask you, they will catch you here. Which is the only glomerular condition that you see, which is the glomerular finding that you see in chronic pyelonephritis, and your answer is in the glomerulus to kuch nahi hai. There is nothing in the glomerulus, but there is something around the glomerulus, and that around the glomerulus is periglomerular fibrosis. I hope everyone knows how to identify a glomerulus. That is, I'm showing it to you again and again. The NEET PG 2023 question was identify the glomerulus. So this is what a glomerulus. I pick it up with this tuft of capillaries. A capillary wala structure is glomerulus. So over here also in this picture, can you all notice? Ye jo capillary wala structure, one glomerulus over here. Let me show you some more. I can see one glomerulus over here also. Many of these laddu type of round glomerular balls I'm going to show you eventually, okay? So chronic pyelonephritis is a tubule problem, but the only glomerular problem is around the glomerulus there is fibrosis. There is periglomerular fibrosis that you see over there. I hope everyone's okay with this. Chronic pyelonephritis ho gaya. The next disease that you have to know in terms of image fest is malakoplakia. What is malakoplakia? Actually, this is not a disease of the kidney. This is a disease which you see kidney ke aage, you see it in the urinary bladder. But let me tell you, malakoplakia is primarily a phagocytosis defect. Everyone remembers phagocytosis from the inflammation chapter. It is primarily a phagocytosis defect, and that means that bacteria will come, like E. coli has come in the body, Proteus has come in the body, but can I kill it? Can I eat it? No. That is what is malakoplakia. So you know what are you going to see? Grossly in malakoplakia, you will see these yellow muco. This is a urinary bladder. I hope everyone's been able to visualize it. Ye bladder hai, then you have the urethra coming out. Hai na? This is the bladder. So remember, you see yellow mucosal plaques. You see the presence of yellow mucosal plaques, and who will see it? The surgeon or the clinician will see it. He's doing a cystoscopy, endoscopy he's doing of the urinary bladder. He says there are some yellow plaques on the camera that I am seeing. Cancer to nahi hai. Is it cancer? Plaques are there. So basically this tends to mimic cancer. So whenever the clinician has a doubt of cancer, whenever there's a doubt of cancer, who comes to his rescue? I come to his rescue. Pathologist comes to his rescue. So he will take a biopsy from here and he will send it to me and he will say, madam, please tell me, is this a case of urinary bladder cancer? And I say, no, not really, because I am seeing blue color ka calcium. I am seeing the blue color wala calcium. What is that calcium? Calcium is nothing but Michaelis Guttman bodies. Please remember, M for M. Malakoplakia shows you Michaelis Guttman bodies which are made up of calcium. It is no cancer happening. It is just, I'll call the clinician and say, "Arey nahi, this is calcium I'm seeing. This is no cancer. It is a case of malakoplakia." What else? We see cells also. What are those cells? They are known as the von Hansmann cell, the scientist. So you know what is it? The von, if I draw the cell, this is a von Hansmann cell. This is nothing but a macrophage. Von Hansmann cell is nothing but a macrophage. So we'll write it as von Hansmann cell, and inside this cell you are seeing the blue color wala calcium. Inside this cell you are seeing the Michaelis Guttman bodies which are nothing but calcium. Has everyone understood? So the full cell is known as the macrophage or the von Hansmann cell. Inside it you are seeing that blue color wala calcium which is the Michaelis Guttman bodies. Sorted. Malakoplakia also done. I hope everyone's okay. So basically it's a phagocytosis problem. So calcium dikhega, von Hansmann cell dikhega. Clinically it will mimic cancer. Coming to the next, the last image fest that you have is the polycystic kidney disease. Guys, polycystic kidney disease, I hope everyone remembers, is either autosomal dominant or it is going to be autosomal recessive. When I say autosomal dominant, you'll say, how have you written it so confidently, ma'am? Just looking at pictures, how can you tell me? When I look at the outer surface of the kidney and when I look at the inner surface of the kidney, both of these are showing me cysts, and I'm seeing cysts on the outer surface also, I'm seeing cysts on the inner surface also. So when the outer surface also shows you cysts and inner surface also shows you cysts, matlab kidney from out will also show cysts, kidney from here will also show cysts. So when everything is showing cysts, तो autosomal dominant hai. How I have learnt it? Autosomal dominant. How do you write this? Autosomal dominant. तो dominant मतलब दोनों cyst. Outside also shows you cysts, inside also shows you cysts. So दोनों cyst is going to be autosomal dominant. Whereas when I talk about autosomal recessive में you will realize that the outer part of the kidney is normal. When I'll show you the kidney, you'll be like, "Arey ma'am, outside is normal." But when I reveal it, when I show you the inside of the kidney, you'll be like, "Oh, it's having cysts. It's having cysts on the inside of the kidney." So please remember that is autosomal recessive. So dominant में दोनों, recessive में it is hiding inside. Cysts are only seen on the inside aspect of the kidney. So that is how I had the superpowers to look at it and tell you. But now let's do the genetic analysis. Please note, for autosomal dominant you had to do doubles. Doubles मतलब square root निकालना है. Chromosome is going to be 16 and 16 का square root मतलब 4. So dominant में हमें basically 2, 4, 16 ऐसे करना है. We have to do squaring, ठीक है. So 2 मतलब दोनों cyst, then chromosome 4, 2 का square 4, 4 का square 16, chromosome 4 and 16. Whereas autosomal recessive में it is going to be chromosome number 6. What is the gene? For autosomal dominant, it is going to be PKD123 or just PKD, polycystic kidney disease. How easy. But for this, it is PKHD gene. I have added the H word in it. Baki PKD is the same. I have added H word. For autosomal dominant, the protein is going to be polycystin. How simple? Polycystic disease, polycystin protein. Whereas for autosomal recessive, it is going to be fibrocystin. So now, if you just pick up autosomal recessive and see extra kya tha, you'll say, ma'am, instead of PKD, you said PKHD, H extra hai. Instead of polycystin, you said fibrocystin. So H and fibro ko milao, H for hepatic, fibro for fibrosis. What else do these patients have other than kidney? What is the problem? Other than kidney, they have congenital hepatic fibrosis. Is it making sense? Full story ho gaya na? Hepatic fibrosis, I have learned from the way that it is PKHD, H for hepatic, and fibrocystin ka fibro liya, to hepatic fibrosis. They ask you this question that other than kidney, what is affected in autosomal recessive PKD? Now you know. And what do you see in autosomal dominant? Dominant mein to bahut sare dominating things are seen. You see ABCD. What is ABCD? ABCD means A for aortic problems like aortic dissection or aortic aortitis, aneurysms. Aorta ka problem hota hai. This condition is more commonly seen in boys. They usually have elevated BP, matlab hypertension, and they tend to have blood in the urine. That is the finding that you see. So what is BBB? They are in boys, elevated BP and blood in the urine. After that, there are cysts present. Ab wo to pata hai, but cysts are present where all? It's just not a kidney problem. Cysts are present in kidney, cysts are present in liver, cysts are present in pancreas, cysts are present in multiple organs of the body. And finally, please remember, CD jod ke, you have colonic diverticula. You have colonic diverticula. So please note, A for aortic dissection, B for boys, BP and blood in the urine. There is C for cysts and CD for colonic diverticula. That is polycystic kidney disease. I hope everyone's understood. I've tried to make like one common flashcard for you guys so that your PKD is like totally sorted. Okay. Now let's move on to the next part. Now there's one more topic in kidney which is very, very important. I'm just mentioning it over here. I'm not taking it up because this is too much of images and obviously I've covered it in a lot of detail under the snapshot or the image section. But please remember, in urine examination, you have to know about the casts and the crystals. There is a set of photos that you will be seeing that is on casts and crystals, which are very, very important, and you have to cover it up from the snapshot section, because I can tell you that there is a definitive one single question that is going to come from this section, right? On that note, what we'll be starting with next is going to be the different nephrotic versus nephritic syndromes. So please note, first I need to tell you the difference between nephrotic and nephritic. So simple. Nephrotic has oh my god kind of things happen, that the levels are oh my god types. How much of protein in the urine? You will say, oh my god, massive proteinuria is in the urine. What is the definition of massive proteinuria? Please remember, it is more than 3.5 grams of protein per 24 hours. More than 3.5 grams of protein per 24 hour in the urine sample. That is going to be massive proteinuria. All the protein is going out into the urine. Not only that, oh my god, type of fat is also going out into the urine. Lipiduria is also going to happen, right? So now think logically, when all the protein has gone out into the urine, so the levels in the blood will be low. Ab sab kuch urine mein chala gaya, so the levels in the blood is going to be low. That is a case of hypoalbuminemia. And whenever someone has low protein, that person lands up with edema. So you will say, okay ma'am, two things are going out in the urine. Na? Protein is going, lipid is going, nothing else? No. Please remember that even things like antithrombin 3 are going to go out in the urine. Things which were stopping the clot formation, things which were protecting me, stopping the clot formation, those stoppers have also gone. So now we are going to have a lot of clot formation. These patients can also land up with thrombotic events. So protein bhi gaya, lipid bhi gaya, antithrombin 3 also is gone. This is what you need to know for nephrotic syndrome. Coming to the next, nephritic syndrome. Nephritic syndrome mein little, not oh my god kind of things, little things are lost. Mild proteinuria happens. What is the definition of mild proteinuria? Less than 1 gram of protein in 24-hour urine sample, right? So in 24 hours of a person's life, 24 hours urine sample, less than 1 gram is little protein. Oh my god, nahi hai, little protein is going. Other than that, there is HOHA. Now what is HOHA that we have to know? HOHA means hypertension. Oliguria means less of urine passage. Hematuria, blood in the urine. And azotemia. Azotemia means elevation of blood urea nitrogen. Blood urea nitrogen levels are elevated. So remember, hypertension, oliguria, hematuria and azotemia. These are going to be the HOHA that you see in a case of nephritic syndrome. Nephrotic may we have oh my god type of proteinuria. Nephritic may we have little proteinuria. So my first thing is that I'm starting with the nephritic syndromes. Okay? Little wala. Under nephritic syndromes, if I ask you, the first one that you have to study is post-streptococcal glomerulonephritis. Post-streptococcal. So what did streptococcal tell you? That it is because of group A beta hemolytic streptococcus. Which streptococcus is this? Group A beta hemolytic streptococcus is Streptococcus pyogenes, है ना? So post-streptococcal, I have learned streptococcus to ho gaya. P for I have learned pediatric. This is the most common nephritic that you see in the pediatric age group. In the pediatric age group, this is the most common nephritic that you notice. You know, there's another name. It is also known as acute proliferative glomerulonephritis, because they will ask you that which glomerulonephritis shows you a lot of proliferation. So acute proliferative glomerulonephritis is PSGN. Now, they will ask you the gross. As you can see, I have told you that we hate PSM wala mnemonic. So, flea-bitten kidney, these pinpoint hemorrhages, hai na? Red color ka pinpoint hemorrhages that we just studied. Another picture that you got in NEET PG, the pinpoint hemorrhages. So, these are the things that you're going to see grossly. What do you see microscopically? Firstly, you look at the immunofluorescence, and immunofluorescence shows you the very famous starry sky pattern. What is starry sky? You see in starry sky. So, starry matlab something is shining and something is dull. Something is blinking, something is dull, है ना? Bright and light, bright and dark, ऐसा कुछ होता है. So over here, if you notice, some areas are coming very bright, shining star like the stars, and some areas are looking very dull. Again, some areas are looking very bright over here, and some areas are looking very dull. So basically, shine and dark, starry sky appearance is what you see in PSGN. Why do you see the starry sky appearance? Because when I went on to the electron microscopy, which is a question that came in the recent NEET PG and the FMG exam, and that is subepithelial humps. Subepithelial, guys, subepithelial. Epithelium matlab podocyte. Dhundo, podocyte dhundo. This is the podocyte. Look at this carefully. This is going to be the podocyte. Suddenly, this one podocyte has become like a mountain. Why is it becoming like a mountain? Because below it, I can see that there is something sitting. There is a subepithelial hump that I am noticing over here. So please remember, subepithelial hump. I'll tell you a mnemonic right in the end that which infection or which glomerulonephritis results in what deposition. Abhi ke liye just keep learning with me. So repeating once again, when I'm talking about PSGN, P for pediatric, streptococcal for of course streptococcal. It is also known as acute proliferative glomerulonephritis. Grossly we see the flea-bitten kidney, microscopically starry sky appearance, subepithelial humps. You've not done the blood test. what do you get to see in the blood test of these patients? So they tend to show you transient hypocomplementemia. What have I written over here? Transient hypocomplementemia. Very, very less amount of time. 6 weeks में ये disease ना अपने आप. Everyone remember PSGN in 6 weeks is going to get okay. You don't have to worry about it. So for those 6 weeks, for that only that 6 week duration, complement levels are gonna be low. There is hypocomplementemia that can happen very transiently. So remember this point, very important in the paper. That wraps up PSGN. So ये था nephritic which you saw in pediatric. But what am I not repeating again and again? अब अगर ये nephritic है, is it understood that it's going to show you HOHA? Hypertension, oliguria, hematuria, azotemia. Hematuria मतलब what is the color of the urine going to be? The color of the urine is going to be the cola colored urine. So it's everything is common in all these nephritics. I won't repeat it again and again. Mild proteinuria and HOHA, cola color urine, ये सब copy paste, ठीक है? So this is going to be pediatrics, that is PSG. And now let's come to adults. Adults के लिए A. So please remember the most common nephritic syndrome that you see in adults and the most common nephritic syndrome that you see all over the world. So AA, the most common in adults and all over the world is IgA nephropathy, please remember, which is known as the Berger's disease. So now, what is Berger's disease? You'll say, ma'am, I have understood IgA. There is what deposition? Name has it. IgA is going to get deposited. Where is it going to get deposited? BE for between, in between. So if this is the glomerulus and these are the capillaries, they are getting deposited, you know where? Between the capillaries. Yahan, this immunofluorescence will be seen beach mein, in between. So that was my mnemonic. Berger's mein, IgA nephropathy tells me that IgA is getting deposited, and Berger's tells me between. The between area is known as mesangium. This area is known as mesangium. So please note, you get to see this green color. This green color is going to be seen in between the capillaries. In between the capillaries, you tend to see them. So you will not see, you're not seeing the green color on the capillaries. No, you're seeing the green color in between the capillaries in the mesangial area. Everyone's understood. So you've understood the names. IgA and Berger's you've understood. Why does it happen? It's an infectious problem. So you will say, "Ek second, ma'am. PSGN was also an infectious problem. Pediatrics wala streptococcal problem. Berger's is also an infectious problem. PSGN was also nephritic syndrome. Berger's is also nephritic syndrome. How will you differentiate? So look at this very carefully. When I'm wanting to differentiate PSGN from Berger's, what am I going to do? First, I will say, acha, dono infectious hai. This means in both of them, first the patient will have sore throat because both of them are infection related. So in both of them, the person will have sore throat, and in the end, in both of them, the person is going to have cola color urine. Cola color urine basically means in both of them, patient will have hematuria. So how will I know what has been given by the examiner? First, I will say, please look at the age. PSGN is going to occur in a child, whereas Berger's is IgA na adult. So this is going to be a history of an adult. You'll say, ma'am, the age was not given in the exam. Then how do I differentiate? You look at the duration between these two things. If it took 10 to 14 days to occur from sore throat to cola color urine, 10 to 14 days have been written, it is PSGN. If a very quick history of 3 days was written, then it is Berger's. So remember, adults mein jaldi happening, that is Berger's. So remember, bade mein Berger. B for bada, J for jaldi. So Berger is bade mein jaldi it is happening, that is going to be Berger's disease. Okay, bade mein, adult mein jaldi. Whereas PSGN is going to be pediatrics and slow. Pediatrics and slow, that is going to be child with 10 to 14 days it is going to take. Okay, that is how you differentiate. And of course, you know the immunofluorescence very well. In PSGN, you shall see the very famous starry sky pattern with subepithelial humps. In Berger's, you're going to see IgA nephropathy, that is going to be in the mesangium. Sorted, everyone? They were infections. Bottom line, they were infections. You treated them, they were fine. Nothing to worry. But you treated them and they did not get fine, then it is a matter to worry. Means if they don't get okay on their own, they will progress to something known as RPGN. What is RPGN? Rapidly progressive glomerulonephritis. It is rapidly progressive glomerulonephritis. So rapidly progressive. Clinician will tell me patient is deteriorating, creatinine levels are increasing, बहुत problem है, rapid deterioration. But वो तो clinician का problem है. I mean, I'm being very crude in saying that, but just on a lighter note, clinician's definition. Now, what is my definition? Rapidly progressive glomerulonephritis is known as crescentric. So what the clinician calls as RPGN, I call as crescentric glomerulonephritis, because we see the presence of these crescents, these half moon shaped kind of structures called crescents. Firstly, you need to know how does it look like. So on this picture, I think everyone can appreciate that this is looking like a half moon structure. Look at it again. Ye glomerulus hai. On top of the glomerulus, I hope everyone can visualize there is a half moon structure that is formed, right? Same way over here, you can notice this is a glomerulus that you have, and on top of it, you have a half moon cap that is sitting. So is there any prognostic significance? Yes, because more the number of crescents, poor is the prognosis of the patient. It's going to carry a poor prognosis for the patient. So if I say 5 crescents or 10 crescents, as I'll keep increasing the number, the clinician is going to be sadder and sadder, because more the number, bad the prognosis. But what is this crescent? What is this crescent made up of? So remember, kaisa dikh raha hai? If this is the glomerulus, crescent is like a flap. So my mnemonic is flap. Simple. My mnemonic is flap. It is made up of number 1 fibrin. L for matlab, it is made up of leukocytes, and flap matlab P, it is made up of parietal and visceral, but more of parietal cells. So it is made up of 3 things. What did I say? Number 1, it is made up of fibrin. Second, it is made up of leukocytes. And third, it is made up of parietal more than visceral. So if you had to select one cell, they say Bowman's capsule ka kaun sa wala cell? Parietal or visceral? You'll say my mnemonic is flap, so I will select parietal. But if they say can parietal and visceral both be present? Yes, both can be present. Okay? So primary mnemonic is flap. याद रहेगा. Now you'll say fine, clinician says rapid deterioration, pathologist says crescent. I know what a crescent is made up of, but what does the electron microscopy expert say? Electron microscopy expert says the favorite movie RRR. And RRR means it is going to be R for RPGN, and that shows you number 1 rupture and number 2 wrinkling. Number 1 rupture and number 2 wrinkling of the basement membrane. So please remember, there is, can you see yahan par there is some black line and there is a black line, but it is broken in between. Matlab there is a rupture, basement membrane is rupture, and not only has it ruptured, it has wrinkled. It has also wrinkled. So please note that there is going to be rupture and the wrinkling of the basement membrane that you notice. RRR, repeating, RPGN shows you rupture and wrinkling of the basement membrane, and that sorts RPGN for you almost. Do you know RPGN is not one disease? It has 3 parts. We all remember it. There is something called RPGN1, RPGN2, RPGN3. So please remember, what is RPGN1? RPGN1 is nothing but good pasture syndrome. RPGN1 is good pasture syndrome, and good pasture syndrome is very famously known as 1, 2, 3, 4. What is 1, 2, 3, 4? Which RPGN have I called it? It is RPGN1. Go back to your immunology chapter. Which hypersensitivity was it? Hypersensitivity 2. But hota kya hai? It is antibodies against alpha 3 chain of which collagen? Of collagen type 4. Collagen 4 matlab basement membrane. Collagen 4 means basement membrane. So repeating, what is good pasture syndrome? Good pasture is a good mnemonic. 1, 2, 3, 4. Type 1 RPGN, type 2 hypersensitivity, alpha 3 chain, type 4 collagen. If you know this 1, 2, 3, 4, good pasture is sorted for you. Also, RPGN1, one line ka immunofluorescence. What did I say? One line. You see a linear immunofluorescence. On RPGN type 1, I get to see one line. There's no shining and dull, no starry sky. One same line, the same green color line. It looks that this pen I took, this green color pen I took, and I have made ek aisa green color ka continuous line I have made all throughout. So it's a one line matlab RPGN1 shows you one line. It shows you a linear pattern. When I come to RPGN2, I realized that all these diseases that I just now studied, PSGN, IgA, so PSGN and IgA, you'll say, ma'am, cheating. You had said PSG and IgA theek ho jate hain within 6 weeks, everything is fine. Yes, but did I tell you that 1 to 2% of cases sometimes don't get okay? Sometimes they can progress and have RPGN, hai na? So which RPGN? RPGN type 2. So simple. If PSGN had starry sky,
This means RPGN2 also has starry sky, that bright and dark, bright and dark. So I can see that there's a very, very bright area over here, and then there's a very dark area over here. Then again there's a bright area here. So like I said, bright and dark, bright and dark. That is what is RPGN type 2. Now coming to RPGN type 3, I've read these diseases somewhere else. M and W, kahan padha hai? We've read it in the blood vessel chapter. Microscopic polyangiitis and vaginous granulomatosis. So microscopic polyangiitis and vaginous granulomatosis is RPGN type 3. And if you remember their names from the blood vessel chapter, they were the pauci-immune ones. Pauci-immune basically means immune is less, immunofluorescence nahi dikhega. There is no immunofluorescence. Good for us. I don't have to see any picture. So a quick recap. When I'm talking about RPGN1, it is going to be 1, 2, 3, 4 and one line ka pattern dikhega. RPGN type 2 is going to be starry sky appearance. RPGN type 3 is pauci-immune, that does not have any immunofluorescence. The last part about nephritic syndromes that you have to know is, right now I told you that there is something, a disease called alpha 3 chain of which collagen? Of type 4 collagen. So you'll say, ma'am, in collagen 4, is there only alpha 3 chain? There can be alpha 4 chain also, there can be alpha 5 chain also. So please remember, alpha 3 chain of type 4 collagen, alpha 4 chain and alpha 5 chain ka problems are different diseases. And what is collagen 4? I told you it is basement membrane, na? I'm making a mnemonic, glomerular basement membrane. Glomerular basement membrane. So how will we learn this? Please note, if alpha 3 chain is a problem, kaun sa disease did I just tell you? I said GPS, good pasture syndrome. If alpha 4 chain is a problem, then what is B? The basement membrane is very, very thin. There is a thin basement membrane disease. And if it is a problem in alpha chain 5, so yes, dekho, alpha 5, alpha penta. So I have written alpha penta. What disease is it? Alport syndrome. It is Alport. So remember, alpha 5, alpha penta problem is Alport syndrome, and with this M, you can invert it and make a W, because Alport syndrome shows you the very, very famous basket weave appearance. Alport syndrome shows you basket weave appearance of the microscope, electron microscope. What is basket weave? I've got you normal and basket weave dono. So normal basement membrane dekho, normal basement membrane is looking like a nice continuous line like this that I can draw. So it's looking like a nice continuous line, hai na? Suddenly I realized that it's broken. Someone has torn the basement membrane. As a fata type of appearance it has, right? So as if I pulled it and I tore it apart. That is what is basket weave appearance. So I'll repeat this concept again. When they say collagen 4 or glomerular basement membrane is affected, you will ask them kaun sa wala chain? 3, 4 or 5, and then you will write GBM on one side, 3, 4, 5 on one side. So 3 chain mein problem hai to good pasture syndrome, 4 chain mein problem hai to basement membrane is very thin, 5 chain penta problem to Alport syndrome. Alport syndrome is going to show you this weave appearance. Easy. But what else does Alport syndrome show you? Alport syndrome is basically a triad, and I have already told you what is that triad. The kidney is involved, and we have studied in the kidney, we have studied that there is definitely a basket weave appearance that we have. Other than that, the eyes are affected and the ears are affected. Ears mein there is sensory neural hearing loss, and eyes mein there is anterior lenticonus. There is anterior lenticonus. So 2 eyes, 2 kidneys, 2 ears. That is what is Alport syndrome. So kidney mein I have showed you basket weave, eyes mein anterior lenticonus, and ears mein sensory neural hearing loss. I hope everyone's okay with this, and we are done with the nephritic syndromes altogether. There's a big tick mark that we can do to nephritic syndromes, because we can now go on to the nephrotic syndromes. When I'm talking about the nephrotic, everything was oh my god type of nephrotic syndrome, massive protein coming, lipid coming. So now we will do 4 disorders under nephrotic. The first one is going to be MCD, minimal change disease, minimal change, minimal age. This is the most common nephrotic that you have in children. This is the most common nephrotic that you see in children. So repeating, there is a minimal age and minimal change. Yaad rahega, pediatric problem hai. Cause, my favorite answer, I don't know. Some people say it is associated with allergy. Some people say it is associated with Hodgkin's lymphoma. Lots and lots of causes. Don't get into it. They really don't know what is the exact cause of it. So then they said that it's got a lot of other names. Do you know minimal change disease is also known as lipoid nephrosis? Why is it called as lipoid nephrosis? Because there is lipoid, there is lipid in the proximal convoluted tubule. Fine. But lipid तो is seen in 1 million disorders. ये तो कुछ significant नहीं है. Then they said, tell me one more name. One more name is nil deposit disease. Nil deposit means immunofluorescence shows you nothing. When I'm not seeing anything, I see something and make the diagnosis. I'm not seeing something, so how will the diagnosis be made? So you'll say, neither is lipid helping me in making the diagnosis. Immunofluorescence is not showing me anything. How do I make the diagnosis? I make the diagnosis by the gold standard, that is electron microscope. Remember, the gold standard of minimal change disease is electron microscope, and that shows you effacement of foot processes. Foot processes तो we identify. This is our favorite now. We can easily label them. ये जो foot processes हैं, so this means this is normal. Suddenly I see in the next picture, the foot processes are not there. They are fused, they are flattened. That is known as effacement. So remember, the gold standard is going to be effacement of the foot processes. And I'm not repeating some things, it is a nephrotic. Nephrotic matlab everything is going to be oh my god types. Massive proteinuria, all the proteins will come out. But please remember, this tends to show you selective proteinuria. Whenever I say, you'll say oh my god type of protein ही है. But selectively which protein is coming out? Selectively albumin is coming out in the urine. So this is a kind of a selective proteinuria. And we all know that whenever we have selective proteinuria, steroids are going to be the treatment of choice. Steroids are going to give you an excellent response. जब भी selective proteinuria होगा, steroids are going to give you an amazing response. So this kid, this 6-10-year-old kid is going to be fine. Kid is done. So now I go on to the adults. What is adults, or what is the most common nephrotic that you see in adults? So the most common in adults is going to be the focal segmental glomerulosclerosis. Repeating, focal segmental glomerulosclerosis. Can you explain this word? When I say glomerulo, I know glomerulus. Okay, very good. When I say sclerosis, sclerosis is going to be some pink material. So you will say, where is this pink material seen? I'll say it is seen in glomerulus. You will say, how many glomerulus? I'll say kuch mein, few of them. Focal basically means that few of them are going to show you these sclerosis. Segmental basically means that a part of them are going to show you the sclerosis. Means if you look at this glomerulus, I will say that this is this ball over here and this ball over here is glomerulus. Where do you see the pink material? Is it like entirely pink? No. If you notice carefully, it has become pink in a certain segment here, in a certain segment here. So segmental. Please remember, and these are just two. If I give you 5 glomeruli, 2-3 ही होंगे. Few of them will be affected. All 5 will not be affected. So few of them will be affected. Only a part of them will be affected, and that is focal segmental glomerulosclerosis. So your question is that why does this happen? This happens because of HRs, that is 3H, 2R and 1S. HRs 3 to 1 means you will either have H, say a patient who's HIV positive, or a patient who's hypertensive, or a patient who is on heroin drug abuse. So HIV, hypertension, heroin drug abuse. What are the 2 R's? Either a person is having some kind of a reflux nephropathy, that is one condition. So there's some reflux happening in the kidney, or there is some loss of tissue. So there is a renal tissue loss that is going to occur. And finally, there is sickle cell anemia. So remember this once again. Either it's HIV, hypertension on heroin drug abuse, so 3 H's. Then you have 2 R's, that is going to be reflux and renal tissue loss. And finally 1 S, and that is sickle cell anemia. So HR's mnemonic yaad rakhna. Then finally they said that FSGS has a classification known as Columbian classification. They love these fancy names. Please note, Columbian classification means, actually there are 5 types. I don't want you to learn 5 types. There are 3 types that I want you to learn. FSGS NOS is the most common type out of these. FSGS glomerular tip, when only the tip is affected. Tip matlab chota sa. This means it has a good prognosis. And when FSG is collapsing, the full kidney has collapsed, glomerulus has collapsed, it's sounding very, very deadly. So this is going to have the worst prognosis. Bas itna yaad rakhna hai that FSG as NOS is the most common, glomerular tip is very, very good, and collapsing type is going to be very, very bad. So now I'll ask you a question which is very, very important. What is HEVAN? HIVAN you might have not heard, but now you have heard. So HIV, so I know what is HIV, associated nephropathy. HIV associated nephropathy. So the first question in the exam will be HIVAN is what? Don't feel you've never heard it. You have. HIV associated nephropathy kaun sa hai? It is focal segmental glomerulosclerosis. They will ask you which type of focal segmental glomerulosclerosis, NOS, tip or collapsing. Socho. HIV is a bad disease, worst disease to have. So the worst kind of FSGS will happen in it. Na? So please remember which kind of FSGS. HIVAN is going to be associated with the collapsing type of FSGS. It's a previous year question that you get. So simple. Childhood wala minimal child wala disease ho gaya. Adult wala FSGS also done. Adult ke baad let us go to elderly. The elderly is going to show you MGN. MGN is membranous glomerulonephropathy. Membranous glomerulonephropathy mein I have, before I tell you the full detailing, there is a way of learning MGN which I want all of you to know. That MGN is the most common that you see in elderly. So you will say at what kind of age? Peak of the age. Peak of the age pe dikhega, one thing, and peak of the pattern will be seen, spike and dome pattern. So remember, MGN is seen on peak of the age and it is seen in peak of the pattern. So why is it seen? Primary MGN is to do with some antibodies. So either there can be antibodies against the phospholipase A2 receptors, that is PLA2 receptors, or there can be antibodies against the thrombospondin, or there can be antibodies against CD10. These are some new updates that I want you to know. MGN can occur because of antibodies against thrombospondin and CD10 also, but what was always known as antibodies against PLA2. Basically, kuch antibody ka problem hai. That is the primary MGN. On the other hand, there is something also known as secondary MGN. What is secondary MGN? Secondary to some drugs. So they could give you a history of, say, NSAIDs. They could give you a history of penicillamine. They could give you a history of gold. So some kind of drugs will be mentioned. Then they could give you infections. Infections may you will have hepatitis B, hepatitis C. Then there is schistosoma. There is going to be syphilis. You might feel the list is lengthy, but it's important. Malaria and leprosy. Malaria and leprosy. So please note HHSS. I tried to make a mnemonic. So hepatitis B, hepatitis C, schistosoma, syphilis, malaria and leprosy. HHSSLL. HBV, HCV, schistosoma, syphilis, malaria and leprosy. These are the infections which can cause MGN. And what are you going to see? Peak of the age pe dikhega, peak of the pattern dikhega. So you will see the spike. So there will be a spike and a dome, spike and a dome, spike and a dome. Spike and dome pattern dikhega. Looks like a little like ECG. So what is this spike and dome pattern? You can see that over here. Can you see this black color ka spikiness coming over here? I've shown you a higher power also. So this black color ka spikiness coming. You will say, why black? In the world of pink and blue, why has the situation become black? Because I have used a stain called the silver stain, the GMS. I hope you all remember the GMS stain, the Gomori methenamine silver stain is the black color stain that you have. So that is what is going to give you that spikiness. And if you ask me what you see microscopically in the electron microscope, subepithelial deposits. Again, subepithelial matlab पैरों के नीचे, podocyte के नीचे, podocyte ढूंढो. Here I can find these tiny little feet, tiny little podocytes are over here. Yes, I can see these podocytes, and below the podocytes I can see these deposits. Below the podocytes I can see these deposits. So again, subepithelial humps are noted over here. So repeated, most common in elderly, peak of the age pe dikhega, peak wala pattern, NEET PG 2023 question, that is spike and dome pattern is seen in membranous glomerulonephropathy. Now, in that membranous glomerulonephropathy, I am going to add a P and make it membranoproliferative glomerulonephropathy. So what is MPGN? Membranoproliferative glomerulonephropathy, which can be of two types, MPGN1 and MPGN2. प्लीज नोट MPGN1, ये MPGN1 है, ये MPGN2 है. MPGN1 shows you the very famous tram track appearance. Tram track, what is tram track? Railway track, na? Railway track matlab two tracks. So if you look very carefully, you shall notice that the basement membrane is split into two parts. The basement membrane is split into two parts. So basically tram track appearance is noted, and this is nothing but a subendothelial. Till now everywhere I was talking about subepithelial deposits. This is subendothelial deposit. And then there is MPGN type 2. MPGN type 2 patients have something in their blood called C3 nephritic factor. C3 nephritic factor is present in the blood, and you know, what did I say? C3. You say, ma'am, C3 matlab complement system. These are the patients who are going to have persistent hypocomplementemia. These are the patients who shall have persistent hypocomplementemia. Very, very important. So there, where did you study? So their complement systems are going to be low. Complement levels will be low forever. Persistent condition hai, because I want to ask all of you, where did you study transient hypocomplementemia? So transient hypocomplementemia was seen in chota wala bachchas. Bachcha tha na, chota chota, for some time it happened and then it's fine. Transient hypocomplementemia happened in PSGN, whereas persistent hypocomplementemia is happening in MPGN, right? Now please note, this type 2 which I'm saying is having a C3 nephritic complement system ka problem, it is known as DDD. What is DDD? It is referred to as the dense deposit disease in the membrane, basement membrane. Can you all see? There is a dark black color dense deposit, dense word ayana. So in the basement membrane, there is a dark black color line, DDD is noted. So simple. Type 1 MPGN shows you tram track appearance with deposit subendothelial. Type 2 MPGN shows you dense deposit disease with deposits in the membrane, and that wraps up your nephrotic syndrome. So nephritic and nephrotics are done, but we are not totally finished with it. Why? Because there are two diseases which are still left which can affect the kidney. We all know that there is a condition called lupus nephritis. Lupus nephritis means that I'm talking about SLE in the kidney. I'm talking about SLE in the kidney, and SLE in the kidney is going to show me three very important findings. Number one, it shows you wire loop lesions. Number one, it shows you wire loop lesions. You will see these heavy pink colored loops that are formed. So wire loop lesions are noted, and that is again going to be subendothelial. That is again going to be subendothelial deposits that are present. Next, when I look at it under the immunofluorescence and the electron microscope, immunofluorescence shows me a full house effect. What is full house? What is this house party happening? All the antibodies come and get deposited over here, IgM, G, A, all complement proteins also come and deposit over here. So basically everyone has gotten together. So they will say this picture will be copy pasted 5 times. They will say this is a picture of IgG, next this is a picture of IgA, this is a picture of IgM, this is a picture of C1, C2, C4. Basically all the antibodies, all the complements, everything comes and gets deposited in the kidney. So full house party. And what is this electron microscopy? This looks something like a thumbprint. We see the thumbprint appearance, very, very important. So please note, here you have wire loop lesions. So agar hum SLE likhe na, it will become very simple. If you write SLE, guys, please note, if you write SLE, you will notice that S matlab that there is some sign. Sign matlab, ya fir in other words, what I have learnt it as, ke you don't know how to sign. When you don't know how to sign karna hi nahi aata. When you don't know how to sign, to kya lagaoge? Thumbprint lagayenge, ma'am. Thumbprint sign is going to be seen over here. Okay. L for loop. We see wire loop lesions. And E for what? Everyone. What is everyone? Everyone is having a house party. Everyone house party matlab full house. That is how you learn. So SLE sign nahi karna aata, to thumbprint. L for loop, wire loop lesions, and E for everyone is gonna get together and a full house party shall happen. That is what you need to know for SLE in the kidney. And please note, before I start with the next disorder, please note that SLE in the kidney is actually going to have many classes, that is class 1 to class 6. But what is important is that the wire loop lesions, which you're calling as the most important, the wire loop lesions are seen in class 3, 4 and 5. Wire loop lesions are going to be seen in class 3, 4 and 5. However, wire has 4 alphabets, loop also has 4 alphabets. So the maximum wire loop lesions are seen in class 4. So repeating, total how many classes? SLE mein total 6 classes. Out of that, wire loop lesions are seen in 3, 4 and 5, and wire and loop which have 4 alphabets, it is class 4 which is going to have the maximum lesions in it, and that is what you need to know for SLE. Coming to the last one, what do you need to know for diabetic nephropathy? When I'm talking about diabetes, when I'm talking about the famous diabetic nephropathy, we can see a very, very famous disorder or a very famous image in front front of us? Kimelstein-Wilson lesion. What is the other name of Kimelstein-Wilson lesion? It is known as nodular glomerulosclerosis. It is known as nodular glomerulosclerosis, and you can see these nodules. ये जो nodule बन रहा है, that is nodular glomerulosclerosis. So they ask you that this is positive for what stain? This is PAS positive. This is said to be PAS positive. Very important. Why am I emphasizing on it? Because nodular glomerulosclerosis is the most characteristic lesion. The most characteristic lesion that you have in diabetes is going to be nodular glomerulosclerosis. Okay, so this is sorted for all of us, and we are done with all the nephrotic, nephritic and SLE and this. But one summary we can quickly do. If I have to tell you what was getting deposited in mesangium, subepithelium, subendothelium and intramembranous, 4 cheeze. So first let me make that list. First they will say, let's finish off the mesangium. When I talk about the mesangium, don't go by the 1, 2, 3, 4 that is written over here. We'll make our own table over here. So when I say mesangium, you will say, ma'am, middle में was beach में. When I say beach में, I am reminded of Berger's disease. So when they are talking about this mesangium, over here what will I do? I will say mesangium में होगा deposition of Berger's disease. Which antibody? It is going to be IgA nephropathy, right? So mesangium to tick mark. Next I go on to the intramembranous, guys, which was the only disease which was known as dense deposit disease. Dense deposit in which the entire membrane, so if I can highlight it, I will say that basically the entire membrane like this was becoming prominent. The entire membrane, right? So that is known as intramembranous disease, and intramembranous disease was MPGN type 2, which is a dense deposit disease, that is intramembranous. So repeating, mesangium में क्या आया? Mesangium में आया Berger's, between Berger's में IgA, and intramembranous में we had MPGN type 2, which is known as dense deposit disease. Now let's look at the confusing ones. The confusing one is going to be subepithelial. The subepithelial is what? Subepithelial matlab below the podocytes. So look at this. If these are the podocytes, I can see someone sitting below it. So you know how I have learnt it? Subepithelial means below the feet, below the podocytes. So now tell me, whose feet do you touch? You touch elders ka feet, hai na? That is what we have been taught. Touch elders, touch the feet of elder people. And who is told? Children are told that, okay, you are younger and you have to touch a person who's elder to you, you have to touch his feet. So ab ek bachcha lo and ek adult lo and put it into this feet wala story. What is the bachcha? So remember, PSGN, remember P for pediatrics. So PSGN is the bachcha over here, and which was the nephrotic that you see in elderly. Elderly wala was membranous glomerulus, elderly age, spike and dome, hai na? So please remember there is a bachcha that is PSGN who is going to touch the feet, and of the feet of an elderly person that is MGN. So these are the two which you see below the podocytes. Coming to the fourth and the last one, which is going to be subendothelial. When we talk about subendothelial, I have two, जो भी रह गया, whatever is left, we have MPGN type 1, and in SLE we have the wire loop lesions. What is subendothelial? Subendothelium is going to be somewhere over here. Somewhere, see, this is the blood vessel. If this is red blood cells, yahan par, this is the blood vessel. So what is subendothelium? Subendothelium is somewhere over here. Please note, this is what you see, whatever is left, MPGN type 1 and wire loop lesions. Repeating. So middle में क्या था? Middle में, between में Berger's. Intramembranous, the name of the disease, dense deposit disease, MPGN type 2. Subepithelial, touch the feet. So a kid will touch the feet of an elderly person. So PSGN for kid and MGN for elderly. And whatever is left, that is subendothelial, that is MPGN type 1 and wire loop lesion. Very, very important summary that you have in kidney. Done with all of this, the last part of kidney that we are going to start with is going to be the renal tumors. You know renal tumors everywhere. Every tumor is divided into benign and malignant. Exactly how I'm going to study it. There are 2 to 3 tables and we shall be sorted with it. Starting off with the benign tumor, the only benign tumor that you have to know is a renal oncocytoma. So what are the 3 points of oncocytoma that you have to know? Number 1, what is the color of this? I can see it has that brownish color है ना, so this is going to have the mahogany brown color. And what is this scar in the center? There is a stellate scar, or there's a stellate scar in the center, so I call it a central stellate scar. Repeating, there's a mahogany brown tumor with a central stellate scar. But why are you calling it oncocytoma? Oncocyte matlab mitochondria. Oncocyte means it's very, very rich in mitochondria. So look at all these round structures. All these round structures are nothing but the mitochondria. So that is why I called it oncocytoma. Remember, mahogany brown color with central stellate scar and lots of mitochondria. That is oncocytoma. Oncocyte matlab mitochondria. So now you will ask me one question. Which are all the conditions in pathology where you see a central stellate scar? No mnemonic needed, but go organ wise. 2 things that you have in kidney, 2 things that you will have in liver, then 1 thing that you will have in the pancreas, and 1 thing in the breast. Okay? So what are the 2 things in the kidney? Abhi we studied oncocytoma, and there's another tumor called chromophobe RCC. So oncocytoma and chromophobe RCC. Liver में FNF, focal nodular hyperplasia and fibrolamellar carcinoma, FNF. Then serous cyst adenocarcinoma of the pancreas and radial scar which you see in the breast. These are all the conditions that show you a central stellate scar like this. 2 in the kidney, 2 in the FNF in the liver, then we have your pancreas and the breast. Now this was about the benign tumor. Coming to the malignant tumor. Malignant, of course, you know that if I'm talking about adults, we are talking about renal cell carcinoma, and if we are talking about children, we are dealing with Wilms tumor. So adults में क्या है? Adults में renal cell carcinoma. Let's get going. There are 6 renal cell carcinomas that you have to know. So clear cell, if you see C for clear, of course it is going to show you C for clear cells, and it is going to be C for the most common type of RCC. So C for clear, C for common, clear cells dikhega. C, A, B, C, third alphabet. So, which chromosome is deleted? Chromosome 3p deletion is there. 1, 2, 3, A, B, C. So, clear mein third chromosome is deleted, and the syndrome is also 1, 2, 3, VHL, 3 alphabets. So, repeating, the most common is clear cell. You see clear cell. Clear is the third number is deleted. That is VHL syndrome. If you want to see a picture, here you go. You see all clear cells. You see all clear cells. So they will ask you a question in the paper. They will ask you a question, what are these clear cells? So remember, these clear cells contain lipid also, and they contain glycogen also. So can you quickly tell me one stain? Ab to itni baar pad liya. What is the stain for lipid? It is going to be oil red O. What is the stain for glycogen? It is going to be PAS. So matlab fatty tumor hai. It contains fat. So sometimes they ask you, which is the renal cell carcinoma which is yellow in color, golden yellow in color. So please remember, because it contains fat, I can always say that this is the only tumor which is going to give me a golden yellow appearance. The only tumor that shall give me a golden yellow gross appearance, golden yellow kidney tumor. ठीक है, clear, crystal clear concepts of clear cell carcinoma. Next, what I move on to is the famous papillary carcinoma. So when I'm talking about papillary, remember papillary should remind you everything to do with papa. What is papa? So papa dad. So this is associated with dialysis. Papa matlab Y chromosome. So this is associated with chromosome Y. Loss of Y. Then papa is a man, of course. Met men. Same sounding. So when there is CMET involvement, which is nothing but trisomy 7. So that is also papillary. Repeating once again, guys. Papillary for papa. So I have done dialysis for papa, met men papa, Y chromosome papa. Okay? And now I'm doing fumarate hydratase deficiency. What is fumarate? So I have learned fuming papa. Fuming papa, if there is fumarate hydratase deficiency that you're going to see, that results in HLRCC. HLRCC matlab hereditary, of course hereditary hai. Fuming papa, fumarate hydratase. Leiomyomatosis. So these patients also have leiomyomatosis with RCC. कौन सा वाला RCC? Papillary RCC. ठीक है? What is HLRCC? It is hereditary leiomyomatosis with papillary RCC. That is a fuming papa, fumarate hydratase deficiency. And don't I know that no matter which papillary carcinoma I talk in the body, samoma bodies हमेशा दिखेगा. That what is the samoma body? So any kind of tumor in the body which shows me samoma bodies, that shall stand for some or the other papillary carcinoma. तो kidney में papillary RCC. Coming to the next one. The next one, the vegetarian tumor. What is vegetarian tumor? Chromophobe RCC. Break the word chromo. Chromo मतलब chromosomes. ठीक है. Phobe. Phobe means phobia, lost. Very scared of chromosomes, runs away from chromosomes. So it's gonna run away from chromosome means chromosomal losses. This is gonna be chromosomal losses, multiple chromosomes. So if they say there is a patient who has loss of chromosome 1, 5, 7, 9, 10, multiple losses, matlab running away from chromosomes, it is chromophobe. Not only is it running away from chromosomes, it's very, very scared of birds and dogs. What is birds and dogs? So this is the scared wala, phobia wala tumor that is associated with the Birt-Hogg-Dube syndrome. So please note, Birt-Hogg-Dube syndrome is number 1 and multiple chromosomal losses is number 2. ठीक है, याद रहेगा. Now, when it is running away from birds and dogs, that's just a way of learning. Birt-Hogg-Dube syndrome sounds like that. When it's running away from birds and dogs, it means it's very, very scared of animals and it loves the plants. It is going to show you the presence of plant cells. Quickly, let's look at plant cells. Plant cells will have a very dark nucleus. Plant cells tend to have a razonoid nucleus, and around the nucleus there is a white area. There is a perinuclear halo. There is a perinuclear halo that you notice. So please remember, there is a very dark nucleus, razonoid nucleus, and around it it's a white area, perinuclear halo. Again, there is a razonoid dark nucleus with white area, dark nucleus, white area. है ना? So all of these are what? These are all the plant cells, and you know plants are very rich in iron. ऐसा बोलते हैं, green leafy vegetables very rich in iron. So which is the stain which is going to be positive for plant cell? Hales colloidal iron. It's not iron stain नहीं है. Iron stain was separate. This is just a way of learning. ठीक है? So remember, plant cells are going to be positive for Hales colloidal iron. So what do I have to know? It is a very nice tumor. It is not killing the animals and it is loving the plants. मतलब it is a very, very good tumor. Vegetarian tumor है. It has the best prognosis. It has the best prognosis. It's a vegetarian tumor. Very, very nice. So if this is the best prognosis, which is the bad one? Belly dance is very, very bad. So how have I learnt it? Haw belly dance. What is haw belly dance? Haw belly dance means, number 1, it's going to show you haw for hobnail cells under the microscope. Microscopically, Bellini duct carcinoma shows you hobnail cells, and it is going to have a very, very bad or has the worst prognosis possible. So what did we learn? We had learned haw belly dance. ठीक है, तो haw मतलब for hobnail cells and haw मतलब we are doing say very, very bad. ठीक है, तो bad मतलब it has bad prognosis. This is everyone will remember. Medullary RCC. Medullary RCC is associated with what? It is associated with sickle cell trait patient, not sickle cell anemia. Sickle cell trait patients. Finally, you said RCC occurs in adults. Now I'm saying RCC can occur in children also. Why will it occur in a chota bacha? If something has to, if you want to convince a chota bacha, you will have to give him toffees, hai na? So remember, it is associated with toffee gene. It is associated with TFE3 gene. So RCC is ideally an adult tumor, but if you have to convince a small kid for it, if you want to consider a small kid for it, you will have to give him some toffees and lure him with toffees. So TFE3 gene for pediatric RCC. So remember, for clear cell, you had to take all the C's and number 3 in order. For papillary, it had to be all papa, fuming papa related. For chromophobe, it was scared of birds and dogs and in love with the plants. For Bellini duct, we did haw belly dance, so hobnail cells and bad prognosis. For medullary, it is sickle cell trait, and for pediatric, it is TFE3 gene. Okay with everyone? The adult tumors are done. We are left with the last tumor, that is the tumor that occurs in children, and that is Wilms tumor. Just 2 things, genetics and picture, bas. When I talk about Wilms tumor, WT1, WT2. Remember, WT1 is going to be present on chromosome 11p13. WT2 is present on 11p15. तो chromosome तो same है, थोड़ा सा change है बाद में. So the way you write WT, you are gonna write WW ऐसा 11p, P for pediatric. Pediatric का tumor है, बच्चों का tumor है, तो 11p is constant over here also, 11p is over here also. You just have to learn 11p13, 11p15, WT1, WT2. When a person has WT1 problem, he suffers from Weger and Dennis-Drash syndrome. What is Weger syndrome? Weger syndrome is going to be W for Wilms tumor, A for aniridia, aniridia means iris is not there, G for genital abnormalities, and R for mental retardation. So repeating, what is Weger? It is Wilms tumor, aniridia, then you have genital abnormalities and mental retardation. Versus there's another syndrome that can occur, Dennis-Drash syndrome. What is Dennis-Drash syndrome? Isme jitna bhi DDD will be written, you're going to go ahead with that. So what is DDD? Means if they say where do you see diffuse mesangial sclerosis, where do you see dysgenesis, so you'll say okay, this D and D, the Dennis and Drash will show me diffuse mesangial sclerosis, gonadal dysgenesis and Wilms tumor though, of course. These are the syndromes with WT1. What is the syndrome with WT2? WT2 ke liye I will draw one very funny looking person. So I will say that one half of his body is hypertrophy. Dekho, one half, hemi-hypertrophy. And you will see his tongue is also coming out. There is macroglossia and of course Wilms tumor will occur. So that is known as Beckwith-Wiedemann syndrome. So Wiedemann syndrome mein kya hai? One half of his body is protruding, basically hemi-hypertrophy, and there is macroglossia. Beckwith-Wiedemann syndrome is what you notice. So simple. For WT1 you have Wager and Dennis-Drash. WT2 is Beckwith-Wiedemann syndrome. So you're done with the genetics. You just need to know under microscopic examination, Wilms tumor is a triphasic tumor. When I say triphasic tumor, it will obviously have three things. Number one, it has the epithelial component. Epithelial component is seen like these round, ye jo structures, tubules dikh raha hai, this is epithelial. The second that you're gonna see is mesenchymal. Mesenchymal is all gonna be the spindle. Ye jaise long cells dikh raha hai, this is all mesenchymal. So I'll use a different color. You can very well see this area over here is mesenchymal. And finally guys, all the blue color cells that you're seeing, blastemal, B for blastemal, B for blue. So all these blue color cells that you're seeing is blastemal. So simple, jo round tubules you're seeing, those are going to be epithelial. All the spindle stromal cells that you're seeing is mesenchymal, and blue color cells are blastemal. So when 1, 2 and 3 things are seen, of course it's a triphasic tumor, and that is going to be Wilms tumor. So remember the genetics, WT1, WT2, remember the fact that it is a triphasic tumor, and with that you wrap up all of your renal tumors as well, benign, malignant, adult and children. Not only that, you wrap up the entire chapter. Yes? So I hope you found this beneficial.
So now let's begin with the central nervous system. There are two very important parts of this chapter that you need to know, which are a must know for the exam. Number one, the neurodegenerative disorders and their images and genetics, and number two, the CNS tumors. We are going to make lots of tables and we'll wrap up in 30 minutes the entire CNS, which is quite a task, but I guarantee we'll be able to do it in the best possible manner. So let's begin. First, I'm starting with the neurodegenerative disorders, and you know Alzheimer's, Parkinson's, then you have the very famous Huntington's and ALS. So first, I'm starting with Alzheimer's disease, and I want to start off with the genetics part of it. So what are the different genes that are responsible for Alzheimer's? There is something known as the amyloid precursor protein, which I have told you way back in your amyloidosis chapter also. Amyloid precursor protein is present on chromosome number 21. So this means chromosome 21 is responsible for this. Then there is something called presenilin 1 and presenilin 2. If you want to actually know their full forms, they are presenilin, and that will remind me that Alzheimer's is a senile age group thing. Na? Alzheimer's occurs at the age of what? 70 and 75. So senile matlab presenilin is going well. But remember the twist over here. Presenilin 1 is not on chromosome 1. Presenilin 2 is on chromosome 1. So 1 is not for 1. Presenilin 1 is actually present on chromosome number 14. And if they further ask you that what are these presenilins going to do, they are increasing the levels of a particular enzyme in the body, and that is known as gamma secretase. They increase gamma secretase. If you go back to the main videos, we have learnt it with the help of a particular mnemonic. I told you that PS, PlayStation is a game, na? So game for gamma. PlayStation basically increases the gamma secretase. And remember, 1 is not on 1. Chromosome 1 pe 1 nahi hota. PS1 is present on chromosome 14 and PS2 is present on chromosome 1. Repeating, both the PlayStations, they release or increase gamma secretase. Coming to ApoE4, ApoE4 is also something that is associated with Alzheimer's. More severe Alzheimer's can occur, and these are all the genetics involved in Alzheimer's disease. So what are the pictures that I'm going to show you? First, Actually, if I ask you previous year questions, Alzheimer's disease involves 5 things under the microscope. I'm going to show you the first 3 things that we have. Neuritic plaques, neurofibrillary tangles, and Hiranobodies. Have a look at these pictures. The first one that we have over here is neuritic plaques. You know what neuritic plaques are made up of? What is their neuritic? You will say, ma'am, common sense. I know neuritic plaques are made up of nerves. Correct. They are made up of these nerves. Yes, you are right. But what is in the center? In the center, we have amyloid. Guys, which type of amyloid is there in Alzheimer's? You've done this in your RR of immunity. Rapid revision mein padha hai. A beta type of amyloid is present. So the center has amyloid and then there are nerves. So this is the first thing, that is going to be the neuritic plaques. What else? We see NFTs. NFTs is not the NFTs that you're seeing on social media nowadays. NFT is neurofibrillary tangles. And let me tell you, in neurofibrillary tangles, you are going to have something known as, they ask you the composition. So, pehle to look how they are seeing. They are appearing like flames. So, many people believe that neurofibrillary tangles are nothing but flame cells. And if they ask you what is it made up of, it is hyperphosphorylated tau protein. It is hyperphosphorylated tau protein, and that is a question that you get in the exam as well. Moving on to the third, Hiranobodies. You can see these needle-like bodies and they ask you what are they made up of. So I'd given you a mnemonic earlier also, hero-coacting. Hero-coacting. So Hiranobodies are made up of actin. So I've told you 3 things. One is the neuritic plaques. Neuritic plaques are of course made up of neuritic nerves and they're made up of amyloid, that is A-beta. Neurofibrillary tangles, which are looking like the flame cells, are made up of hyperphosphorylated tau protein, and the Hiranobodies are made up of actin. Now out of this they will ask you that all these are pink and blue, but what are these 2 set of weird looking stains? So please note, this is referred to as the Biel-Shofsky stain. In the brain, this stain that we use is the brain ke liye Biel-Shofsky. Remember, brain ke liye we are going to use the Biel-Shofsky stain. Coming back, so you are done with the 3 things. You are done with neuritic plaques, neurofibrillary tangles, and Hiranobodies, and 2 more things you have to do without any pictures. Alzheimer's also affects the blood vessels, that is angio. Angio matlab blood vessel, na? So there is amyloid angiopathy, cerebral amyloid angiopathy. It also affects the blood vessels. Secondly, it can cause degenerative changes, granulovascular degeneration. So when you read it, it's sounding very, very scary, na? But if you go into a basic thing, number 1, you say, okay, it involves the blood vessels, that is, it causes an angiopathy. Number 2, it causes a degeneration, which is known as granular vascular degeneration. So these are the 5 things that we have in total for what are there in cases of Alzheimer's disease. With these 3 pictures. I hope this is okay. This was the toughest one. You've done the genetics, you've done the microscopy. Now let's move on to Parkinson's disease. We all know what is Parkinson's disease. Parkinson's disease happens to be a basic defect that is occurring in a gene called alpha-synuclein. There is a defect that occurs in alpha-synuclein, and because of this, what happens? There is a decrease in which neurons? Come on guys, from your basic medicine, there's a decrease in dopaminergic neurons that it has in Parkinson's disease, hai na? So what is it going to be showing you under the microscope? So think logically, agar alpha-synuclein is the problem, then microscopically also I will see something to do with alpha-synuclein, and that is the Lewy bodies. Now many students forget which body is seen in which particular condition. So they forget Lewy body is seen in Alzheimer's or Lewy body is seen in Parkinson's. Remember, park and lawn. If I say there are students or kids are playing in the park or kids are playing in the lawn, same thing, na? Park and lawn are synonyms. They are the same thing. So park and lawn are synonyms. Se yaad aaya that Parkinson's disease shows you Lewy bodies, and synonyms means it is alpha-synuclein. Have a look at this picture. This is a case of Parkinson's disease, and in Parkinson's disease, I just now told you that there is a decrease in the dopaminergic neurons. If there is a decrease in the dopaminergic neurons, basically means that there is a decrease in dopa. In simple words. And if there is a decrease in dopa, that further means that there is going to be a decrease in melanin. Dopa is a precursor of what? Melanin. Guys, go back to the first chapter. Which part of the brain has melanin? It's the substantia nigra. So normally the substantia nigra was supposed to have a lot of brown, yahan par, a lot of brown color pigment, melanin. But now I'm saying because the dopaminergic neurons are not there, dopa is not there, melanin is not there. So can I say now what I'll see will be a very pale substantia nigra. The brown color will be less. That is one thing that you see in Parkinson's with its pathogenesis. Next thing I told you that park and lawn. So Parkinson's shows you Lewy bodies and synonyms. Matlab Lewy body is made up of what? It is made up of alpha synuclein. This round structure is a Lewy body. This round structure out here, that's a Lewy body. So remember this mnemonic, park and lawns are synonyms. This was also a question that came in NEET PG 2023. Now moving on to the third disorder, and the third disorder is Huntington disease. This is not going to show you any kind of, bodies or any microscopic appearance, but definitely please note that Huntington is something you've studied way back in your genetics chapter, because I had taught you hunting in a cage. What was hunting in a cage? Please remember I told you hunting in a cage matlab, that is CAG repeats were present in which part? E for exon. CAG repeats were present on the exon, and this is on chromosome 4. So remember, hunting in a cage, CAGE. Cage is what? 4 alphabets na, to chromosome 4. What is happening on chromosome 4? In the E for exon, which repeats are happening? CAG repeats are happening. And when this happens, what are the two proteins that are going to increase? अब think logically, no one will ask you कि Huntington disease में Huntington protein is increasing. ये तो common sense हो गया. What they will ask you is ubiquitin increases in which disorder? So Huntington and ubiquitin increase in Huntington disease. And do you know where? Which nucleus? This all occurs in the caudate nucleus. This is also a very important question. Caudate nucleus is what is going to be there. Let me do a quick recap. When I'm saying Huntington, you will say hunting in a cage. Cage has 4 alphabets. This is a chromosome 4 problem. Cage has CAG, so there are CAG repeats on E for exon. The proteins, of course, in Huntington will be Huntington increase and ubiquitin, where in the caudate nucleus. Coming to the last one, what is ALS? ALS stands for amyotrophic lateral sclerosis. Repeating, this is a disorder that you have studied earlier in medicine. In the first chapter also I have taught you in the RR, and also this is a disorder that Stephen Hawking had. So amyotrophic lateral sclerosis, let's write the full name because this might come out to you in your exam also. Amyotrophic lateral sclerosis, just 2 questions. Question number 1, what is the genetics? Why did I teach you way back in your first chapter? Because this is a superoxide dismutase gene defect. There is a SORT gene problem, and if they ask you that what are the bodies that you're going to see in them, we are going to see the Bunina bodies. Another bodies added up. Koi confusion nahi hoga. Bunina bodies are seen in amyotrophic lateral sclerosis. Lewy bodies are Park and Lawn, so Lewy bodies are seen in Parkinson's, and Hero ko acting karana tha, acting in Alzheimer's. So please remember Hirano bodies are actin and they are seen in Alzheimer's. So quick revision of the neurodegenerative disorders is done for us. Now we are going to move on to the next part, and that is going to be the brain tumors. Now before I start with the brain tumors, of course I'm going to first start off with the grading aspect of it. So if you all remember, brain tumors ka grading was done by a mnemonic called AMEN. You should first know the full form of AMEN. AMEN means that A is going to be for atypia, M for mitosis, E for endothelial matlab blood vessel proliferation, and N for necrosis. पहले याद कर लिया, atypia, mitosis, endothelial proliferation and necrosis. Now my work is that how am I going to divide it? So remember, brain tumors go for grade 1, grade 2, grade 3 and grade 4. Grade 1, which is of course the bestest tumor to have, if at all, and grade 4 is the worst tumor to have. So the prognosis is also in front of you. But how do I know it is grade 1, 2, 3, 4? I am going to make grade 1 mein there is nothing. Out of AMEN, everything is absent. No atypia, no mitosis, no endothelial proliferation, no necrosis. Grade 2 mein only atypia is there. Grade 3 mein atypia and mitosis is there. Grade 4 mein out of AMEN there are 4 things na, at least 3 out of 4 have to be present. So repeating, grade 1 to sabse acha because nothing is there. Grade 2 mein the A is there, then take the A and M, that is grade 3, then take all of them, at least 3 out of them, grade 4. Repeating, kuch bhi nahi hai, 1 grade. Only atypia, grade 2. Atypia and mitosis, grade 3. And if all of them are present, grade 4. Everyone's understood this? Now I can start with the diseases. The first disease that I'm starting with is pilocytic astrocytoma, and in the exam they refer to it as JPA, juvenile pilocytic astrocytoma. So if it is written as JPA, it means the same. Juvenile, child. Remember in the exam your take home point is if you see a CCC tumor. CCC means if there is a child and he's a very bigda hua child. This brat bigda hua child means it's going to show you the BRAF mutation. So if you see a BRAF child, brat child who has a cystic lesion in the cerebellum, who has a cystic lesion in the cerebellum. So here you can see very beautifully there is a cystic lesion present in the cerebellum, and of course this is going to be showing you the very famous, how I have learnt it is pylo. Pylo means hair, तो कुछ hairy like है, and that hairy like is rosenthal fiber. So what you can see over here guys in this picture are the very famous rosenthal fibers. Repeating once again, we see pilocytic astrocytoma, तो pylo matlab rosenthal fibers, and CCC, there's a child with a cystic lesion in the cerebellum. That child is very naughty, BRAF child. Remember, this is a grade 1 tumor, and I know that grade 1 tumor has the best prognosis possible. So simple, in the exam, if I have to pick up JPA, I have to go for CCC. That will be my take home point. This was child, and this was very nice. Now I'm going to go on to the other one. The one in adult, and that is going to be very bad. And what is that? That is the glioblastomas. Now, having discussed the juvenile pilocytic astrocytoma, we are going to start off with glioblastoma. So when we are talking about glioblastoma, see, as soon as I use the word blast anywhere in the brain, glioblastoma, medulloblastoma, pinealoblastoma, any other blastoma, blastoma means bomb blast, which basically means that the grade is going to be 4 and the prognosis is going to be very bad. Pathetic prognosis. Bomb blast means very bad. Remember one more thing, glioblastoma, because bomb blast is very bad, so grading and all we have done, but glioblastoma has something nice also. It has all wildlife, nature, butterflies, snakes, pets, wildlife. Yes, sub animals are going to be there. So please note that when I'm talking about glioblastoma, they will ask you the genetics, and that is why I've written it as a box. It's very important. 90% of the cases show you IDH of the wild type. IDH is an enzyme in biochemistry, isocitrate dehydrogenase. Wild type. I told you, wild life is very important. 90% are wild type, and only 10% of them are going to be IDH of the mutant type. Rest all of them are going to be wild type. So wildlife is important. Now let's come to the images. Under the images, when I first look at this picture over here, I can see that it's looking like a butterfly. Left pe bhi hai, right pe bhi hai. So this is known as the butterfly glioma. I told you, butterflies, nature will come. Let me look at the microscopy. Microscopically, when I look at the necrosis is as a wavy like a snake. So what I call it is the serpentine necrosis. I can very well see the serpentine necrosis here. So where are the cancer cells? Necrosis to ho gaya. The cancer cells are around it. So when I look carefully over here, I can see that there are ... lots of cancer cells around it. This is known as pseudo-palisading of the tumor cells. Pseudo-palisading, wo ... tumor cells are there. And finally, please remember, GB shows you GB. You won't get a picture on it, but it's definitely important. GB shows you GB, that is glomeruloid bodies are seen in glioblastoma. You've done all the microscopic and the gross findings. So first and foremost, it is known as a butterfly glioma that you can see over here. Second, it shows you the presence of this wavy serpentine necrosis. Third, it shows you the pseudo-palisading of the tumor cells. And fourth, it shows you GB mein GB. Glioblastoma shows you glomeruloid bodies. I've told you it's a bomb blast and it's very bad. Coming to the next tumor, there is a tumor which is oligodendroglioma. I don't like writing oligodendroglioma like this. I am going to erase it from here and I am going to write it the way I like to write it. And that is, I hope all of you know, it is oligodendroglioma. So how did I write it? I have written all the andas, the big eggs I have made. Oligodendroglioma, because this will always remind me that this is the tumor that is showing me the classical fried egg appearance. So please note, the first picture that you have to know is the fried egg appearance. What is the fried egg appearance? This is a cell, for example, and you have a nucleus, but around the nucleus it's all white. So if you zoom into this picture and see, around the nucleus, if you see there is a white area, that is the fried egg. Just like you have a fried egg over here, around the nucleus you have a white area, or matlab, agar if we write it in pathology terms, perinuclear halo. you see the presence of perinuclear halo. But there is one more rule. Whenever in life you will find an egg, you will find a chicken. So what is the next thing that you see? I see the presence of chicken wire blood vessels. I can see this characteristically over here. We see the presence of these chicken wire, these lines, these chicken wire blood vessels are seen. And one more thing, this tumor tends to show you calcification. So guys, can you make a list for me for all the tumors in the brain that show me calcification? So tumors in the brain showing you calcification on radiology are COM, means there's a tumor known as craniopharyngioma. Then there is a tumor called oligodendroglioma, very, very important, oligodendroglioma. And finally, there is a condition known as meningioma. So, whenever the radiologist says that there is a tumor in the brain showing you calcification, you have to think of COM. Craniopharyngioma, oligodendroglioma and meningioma. These all show you calcification. So, repeating, firstly, we see fried egg appearance. Wherever there is an egg, there has to be a chicken. So, there is chicken via blood vessels, and we see calcification. Calcification is seen in the COM tumors. Now asking you the genetics. You know the genetics over here is also isocitrate dehydrogenase. That is the most common. So isocitrate dehydrogenase was in glioblastoma also. Na? It's over here also. So in fact, if you ask me what are all the tumors everywhere in pathology which have isocitrate dehydrogenase mutation, I will say that I am egoistic. That is the mnemonic. Okay, what is I am egoistic? I am egoistic tells me that I for isocitrate dehydrogenase, G I just studied glioblastoma, O I am just studying oligodendroglioma, and E is a bone tumor, that is enchondroma. So remember, enchondroma, glioblastoma and oligodendroglioma, these are the ones which are I am egoistic. These are the ones showing you isocitrate dehydrogenase mutation. So that is the most common mutation that you see over here also. But please remember, there is another thing that I see over here, very famously known as co-deletion 1p19q. Two chromosomes are getting deleted. Small number, small arm, big number, big arm. That is how I've learned it. Small number के साथ small arm delete करना 1p, and big number के साथ big arm delete करना 19q. Co-deletion 1p19q, and if this happens, it is associated with a good response to chemotherapy. Actually, these patients are going to show you a better response to the treatment. So if as a pathologist I have said this is an oligodendroglioma and the genetics expert tells me it shows you co-deletion 1p19q, clinician is actually in a way happier, because this means the patient is going to have a better response to chemotherapy. So on that note, everything about oligodendroglioma is done, but one revision you have to do. Can you tell me all the things in pathology that have fried eggs and all the things that have chicken wires? Make two quick lists for me. Firstly, tell me all the fried eggs. So what is the brain tumor that we studied right now? Oligodendroglioma ho gaya. Think where in the bone marrow biopsy, only one condition on bone marrow biopsy which shows you fried egg appearance was hairy cell leukemia. Very important question. Next, which are the tumors of the testis and the ovary? Which is that tumor which can occur in testis and it can occur in ovary, but it has different names? Seminoma, dysgerminoma. So we had studied that if it occurs in the testis, I call it seminoma. If it occurs in the ovary, I call it dysgerminoma. Yes. So these can occur and they also show you fried egg appearance. But we are not only limited to patho. We are also going to study micro. Which are the two microbiology colonies which are going to show you fried egg appearance? M and M. M and M matlab, number one, the mycoplasma colonies are fried egg and Malassezia furfur is fried egg. So M and M, mycoplasma, repeating, mycoplasma and Malassezia furfur, fried egg. I hope fried eggs are okay with everyone. Similarly, we have to do all the chicken wires. What is it about chicken wires? So over here, guys, I asked you chicken wire blood vessels. Exactly. So if I've asked you chicken wire blood vessels in the brain, I am talking about oligodendroglioma, right? But if the same chicken wire blood vessels I ask you in the breast, the same chicken wire blood vessels on a breast FNAC is seen in a tumor known as mucinous or colloid carcinoma. It is seen in association with mucinous or colloid carcinoma. Then, if you've read the liver chapter, where do you see chicken wire fibrosis? It is seen in alcoholic liver disease. It shows you chicken wire fibrosis. Alcohol ke saath chicken to of course everyone consumes, na? So alcoholic liver disease mein chicken wire fibrosis dikhega. And finally, what is the bone tumor that shows you chicken wire calcification? That is seen in chondroblastoma. The bone tumor showing you chicken wire calcification is going to be chondroblastoma. I hope this will help you all. Very, very important thing that you have to know for chicken wire. Similarly, very important table for fried eggs. Why did we study this? Because today we are studying a bone tumor called oligodendroglioma. This is also done. Shall we move forward? The next bone tumor that we have to go on to is known as ependymoma. Now just think logically. Where is ependymoma? Ependymal cells, ventricles. Na? So what is going to be the most common site? The most common site in children is going to be the fourth ventricle, because ependymal cells are only present in the ventricles, hai na? So now this is associated with a syndrome called NF2. NF2 2 और add कर दो, that becomes chromosome 22. NF2 2 chromosome 22. And what are all the brain tumors that are seen in NF2? We have a very famous mnemonic known as Miss Me. NF2 miss you 2 types. NF2 that is going to be miss me tumors. Miss me tumors mein E to I have understood. Why am I studying E over here? I am studying it because it is going to be ependymoma. Very shortly we will also study a tumor that is meningioma. That is also seen in NF2. But what is this MIS? MIS, either you want to learn the full form of schwannoma, so you know na, NF2 is actually nothing but schwannomas. So they have called it multiple inherited schwannomas. They have called it multiple inherited schwannomas. So repeating once again, NF2 is miss me, that is multiple inherited schwannomas. Then we have meningiomas, then we have ependymomas. That is the miss me mnemonic for NF2 that you have to know. So what is ependymoma going to show you? It shows you a very famous rosette known as the perivascular pseudorosette. I'm coming to the rosettes in a while. This is perivascular. Perivascular means I can very well see a blood vessel, perfectly seen. I can see a blood vessel over here, and then I can see the tumor cells around it. So yes, perivascular pseudorosette is noted. I hope everyone's okay. Ependymoma ventricle mein hota hai, that is the site of the ventricle, the ependymal cells. Perivascular pseudorosette is seen. NF2 miss me mnemonic, that is what it's a part of it. And now I'll tell you something advanced. An update says there is something known as a RELA fusion ependymoma. What is RELA fusion ependymoma? So look at this. First and foremost, R will remind you that okay, the name of the gene is the RELA gene. As soon as I say a gene, you will say, ma'am, chromosome batao. EL will remind you that it is present on chromosome number 11. It is present on chromosome number 11. Next, you will ask me which brain tumor is it associated with? E for ependymoma. E for ependymoma. But what is different about it? A for above. Above the tentorium. It is above the tentorium. Basically, whenever I'm talking about ependymomas and you are saying this is occurring in the fourth ventricle and then the spinal cord, these are all below, infratentorial. Usually they are infratentorial. I am saying that jo RELA fusion wala ependymoma hai, that is going to be above the tentorium. So I hope everyone's okay with this. R for RELA fusion, EL for 11 chromosome, A for above the tentorium, and E for ependymoma that it causes. Okay. RELA fusion ependymoma could be a question in your INI, CET and other exams. Okay. So ependymoma also sorted for us. What are we moving on to next? We are going on to the medulloblastoma. Tell me one thing, as soon as I say blastoma, grading kya lag raha hai? Blastoma, bomb blast, grade 4, very, very bad. Sorted. Now please remember that there are 4 categories which I want to introduce you to. There is a WNT mutation, SHH mutation. Third category, no WNT, no SHH. Fourth category is also no WNT, no SHH. So difference kya hai? First one is okay, WNT mutation. Second one, SHH mutation. What is the difference between this third, no WNT, no SHH, no WNT, no SHH? Isme difference kya hai? Please note that now I'll tell you something extra. The second and the third, these 2 categories, the SHH wala and the third wala, they are very famous for showing you NMIC mutations. And then the third and the fourth categories, they are very famous for showing you isochromosome 17q. So ultimately, now can you see the difference? So first wala is only WNT, second is SHH and NMIC, Third is no WNT, no SHH, but it has NMIC and it has isochromosome 17q. Fourth one is no WNT, no SHH and it only has isochromosome 17q. तो अब ऐसे याद करोगे तो it's gonna be very difficult. So my advice to you is learn it like this. There is first WNT pathway problem, SHH pathway problem. Third and fourth are no WNT, no SHH, no WNT, no SHH. Then the second and the third are going to have NMIC problem. The third and the fourth are going to have isochromosome 17q. And what am I going to see microscopically? There's a very famous rosette that you see, the Homer Wright pseudo rosette. Before I go on to telling you the different types of rosettes, can you recall for me a mnemonic that where all in pathology do you see Homer Wright pseudo rosettes? So we had done men are right or men are fake, whatever life has taught you. Either you believe men are right or you believe men are fake, but your mnemonic is men. Means the tumor that I'm talking about over here, that is medulloblastoma, is going to show you these rosettes. There's another blastoma known as neuroblastoma which shows these rosettes, and finally there's a bone tumor that is Ewing sarcoma that is also going to show you these. So men are right or men are fake, that is what you have as Homer Wright pseudo rosette. So medulloblastoma to ho gaya, but I want to see the picture of this Homer Wright pseudo rosette and I just want to look at rosettes in general. What is the concept that you have behind a pseudo rosette and a true rosette? These are the two rosettes that I want to find out. So remember, rosette matlab aisa round, round, round. Tumor cells are going to be present round, round, round. What is in the center makes a difference. If the center has some material, if the center is filled, this means you are dealing with a pseudo rosette. And if the center is empty, this means you are dealing with a true rosette. So how am I going to learn this? Life lessons. True people are clear-hearted. They have no hidden intentions, clear-hearted, clear center. So true people are clear-hearted. Whereas fake people, they have some bad intentions in their heart. So देखो, fake people में something is filled. Fake people में something is going to be filled in their heart. Whereas true people are nice people, they are totally clear-hearted. याद रहेगा? So Homer Wright pseudo rosette, pseudo is fake, means it has some pink material in the center. Have a look at this picture. I can very well notice that yes, there are some round cells and there is a lot of material that is present in the center. Same way there are round cells and there is a lot of material that is present in the center. So this is a fake rosette. Versus if I look at the next one, the other one is round cells, but the center is empty, white hai. Round cells and the center is white. Center is clear, heart is clear. This is a true rosette. Where do you see a true rosette? True rosette is known as Flexner Wintersteiner rosette. See, not only are true people clear-hearted, true people are also very flexible and nice. Aise yaad karo. So true people are not only clear-hearted, they are also very flexible and nice. So Flexner Wintersteiner is a true rosette that you see in an eye tumor, that is retinoblastoma. Now you've done all the rosettes. A quick recap. Where did I teach you perivascular pseudo rosette? देखो यहाँ पे भी I use the word pseudo. Why did I use the word pseudo? Something has to be filled in the center. What was filled in the center? Perivascular. Center में blood vessel था, तो of course anything in the center मतलब it's a bad thing, it's a fake thing. So in the center you had a blood vessel, so perivascular pseudo rosette is seen in ependymoma. Homer Wright pseudo rosette, I have told you, it is seen men are pseudo. Homer Wright, men are right, men are fake. So medulloblastoma, Ewing sarcoma, neuroblastoma. And finally the true one, the flexible one, Flexner Wintersteiner rosette, that is seen in retinoblastoma. On that note, we move on to the next one, and that is meningioma. Meningioma is also associated with NF2 because did I teach you that Miss Me mnemonic? उसके अंदर Miss Me mnemonic में M was meningioma. So yes, this is associated with NF2, and this is the most important question. It is associated with females. Females का history होगा या some pregnancy history, something to do with female history will be there, because this is the only brain tumor which is progesterone receptor positive. Progesterone receptor female, this is the only brain tumor which is progesterone receptor positive that you have to know. I hope that's okay. So meningioma, females में. Now what are these pictures that I'm going to see? So first and foremost, you can see a tumor over here which is arising from the meninges. There is a tumor over here which is arising from the meninges. That is my first sign. And guys, let me ask you a little bit of radiology also over here. What do you see radiologically? You see the very famous dural tail sign. Dural tail sign is noted radiologically, है ना? And what do you see microscopically? Everything is going goal. What is goal? The cells are also going goal. whirl means whirling. You can see the cells are going round and round, and that is going to be whirling of the tumor cells. And second is going to be samoma bodies. Samoma bodies is also calcium going round, round, round. So I can see the calcium also over here going round. So everything is going round and round. The cells are also going round and round. The calcium is also going round and round. So the round and round, females doing round and round. Some student once in a live class, offline class, told me, ma'am, women do a lot of aisa gol gol baatein, gol gol talks. They do a lot of gol gol talks. So women wala jo tumor aa raha hai na brain mein, that is that women have in their brain, they have a lot of swirls and things happening, a lot of complications happening. So females wala jo brain tumor hai, that is going to be everything round and round tumor cells, round and round calcium. That is what you have for meningioma. Now what we are left with is the last slide of this, but definitely a lot of things, but all miscellaneous ones I have put under one table. So there is something known as a brain tumor called ATAR. For those who don't know, sabka images we won't be knowing. ATAR is atypical teratoid, AT for atypical teratoid, and AR for atypical rhabdoid. So atypical teratoid and atypical rhabdoid, they only ask you what is the genetic problem, that is the SNF-INI. How have I learnt it? Rhabdoid matlab rabies na, rabies dogs, rabid dogs is rhabdo. So rabies dogs sniff. Dogs sniff. So rhabdoid mein sniff, SNF gene mutation is gonna be there. Coming to next, there is something known as DNET. DNET mein you get a question. Firstly, what is DNET? DNET is associated with a dysembryoplastic neuroepithelial tumor. So dysembryoplastic, remember, it's a dysembryoplastic neuroepithelial tumor. And remember, dysembryoplastic mein hame ye dikhega, lots of pools of mucin. I have called them as pools of mucin. So have a look at this. Can you see these neurons? Ye aisa kuch chota chota neurons. So what have I called them? They are going to be floating neurons. We call them as floating neurons. And what we see in the background is pura water. So there's going to be pools of mucin. I see floating neurons in the pools of mucin. That is what is DNET. Coming to the next, that is schwannoma. Schwannoma, I have already told you, it's a part of NF2. NF2 matlab miss me mnemonic. So I have told you over there that multiple inherited schwannomas are going to occur. The only question further that you have to know out here is, how is schwannoma going to look microscopically? So please note, schwannoma has three very important things to show you. Antennae A areas. Before I show you the pictures, antennae A area is hypercellular. Means antennae A has a lot of cells. That is how I have learnt it. Antennae A has a lot of cells. Antennae B area is hypocellular. How will we learn that? B is going to be blank. B is going to be blank. B is going to have very few cells. So remember, A is going to have a lot of cells and B is going to be blank. And finally, you see a body called Verrucke bodies. Let's have a look at these pictures and clear it off. What are we seeing? Look at this area, guys. We are seeing lots of cells over here. A lot of cells means this is antennae A area. Over here, I'm hardly seeing any cells. It's all white. So this is blank. Blank matlab antennae B area. Sorted. Antennae A, antennae B. I hope schwannoma is coming across. Antennae A, antennae B clear. Now I just have to know what is it with Verrucke bodies. Remember, for the Verrucke bodies, I am going to visualize this as, look at this picture that I've drawn. Blue color nuclei, blue color nuclei. There are two rows of palisading nuclei. There are two rows of palisading nuclei. So where did all the cytoplasm go? The cytoplasm is in the center. So what do I see over here? I have, look at this, guys. Let's remove the labeling. I can see there is one row of nucleus over here, one row of nucleus over here. So have I seen the two rows of palisading nuclei? They clear. And then what do you have over here in the between? You have the pink colored cytoplasm. So this entire thing now tells me this entire thing becomes a Verrucke body. Simple. So for schwannoma, you just have to learn antennae A, antennae B and Verrucke bodies. Coming to lymphomas. Lymphomas in the brain are usually seen in an HIV positive situation and they are usually DLBCL. HIV positive case and DLBCL is the most common lymphoma that you have, and this is now associated with two very important patterns which you notice: angiocentric pattern and whooping pattern. This is not important for FMG students, this is important for INI especially. So what is angiocentric pattern? Lymphoma of the brain, which is most commonly DLBCL. You will realize that angio, word angio means blood vessel, centric means centered. It is an angiocentric pattern pattern around the blood vessels. So the tumor cells are around the blood vessels. They are around the blood vessels. So they are always centered around the blood vessels. That is angiocentric pattern. Coming to the next thing, and that is going to be hooping. What is hooping, guys? Hooping means that, like for example, if this is a cell, fiber is around it. This is a cell, hoop kar liya. Looping, hooping, same thing. If this is a cell, fiber is around it. So can you see these reticulin, black color reticulin fibers? Yes. So please note that these reticulin fibers are going to be the hooping part around it. So if this is a cell, fiber around. This is a cell, fiber around. So ये जो बीच में fibers जा रहे हैं, these are all the hooping pattern. That is what you see in a case of a lymphoma. That is angiocentric pattern and hooping pattern. Coming to the last one, this is a new tumor, a new update, diffuse midline glioma. Break karo and you'll get everything. Firstly, glioma, of course, brain tumor. Midline, it occurs in the midline of the brain. Diffuse, it's not at one place, it is spreading around. If it's spreading around, is it good or bad? Obviously, it is going to have a poor prognosis. It is going to have a poor prognosis. And now they ask you, what is the genetic mutation that you have? That is the question of the most expected hot topic, trending topic. So remember, it is H3K27M mutation. If you can't learn the full thing, at least learn H3. H3 matlab histone. It's a problem in the DNA histone that they've come across. So ye new hai, this every exam student has to know. Diffuse midline glioma shows you H3K27M mutation, and it is going to carry a poor prognosis. So this last table mein, of course, all the miscellaneous chota tumors are there, but they are important. So quick revision: ATAR mein rhabdoid pada to sniffing, SNF mutation. DNET is going to be floating neurons in pools of mucin. Schwannoma ke liye Antony A, Antony B, and the very famous Verruke bodies. Lymphoma is usually HIV positive patient with DLBCL is the most common lymphoma. And diffuse midline glioma, so it's a new tumor, H3K27M mutation, very, very important. On that note, we have definitely wrapped up our entire discussion of CNS, not only the neurodegenerative with genetics, but also the tumors. Now let's begin with the rapid review of female genital system. Now my piece of advice for you over here is that when you're referring to the genital system, go through the female genital system first and then go on to the male genital system, because I'm discussing all the ovarian tumors here, and then there is so much of overlap that happens with the ovarian tumors and the testicular tumors that most of it is going to be a repeat there, so I'm not going to repeat it again to not add on to your bulk. Whatever we are going to study here is going to be a complete copy paste in the male genital system as well. So when I come to female genital system, before I jump on to the ovarian tumors, I first want to tell you something about the uterus, and in the uterus I want to talk about the most famous pass-fail question, and that is leiomyoma. Leiomyoma, oma obviously means a benign tumor, and leiomyo basically means it's a benign tumor of the smooth muscle. It is a smooth muscle benign tumor that you have. So what are the different types of leiomyoma in the uterus that you have? You can see three that are labeled here. Firstly, you'll see one just below the cavity, submucosal, just below the mucosa, and then you'll see just below the outer covering, that is going to be subserosal. So just below the inner covering is submucosal, just below the outer covering is subserosal, and then what is stuck in between is intramural. What is going to be stuck in between is going to be intramural. These are the three types of leiomyomas that you have, and obviously the patient is going to come to you with bleeding. There is going to be bleeding, but maximum bleeding or maximum chances of bleeding will be the one that is closest. The closest to the cavity will bleed the most. So the maximum chances is going to be the submucosal leiomyoma. Now, why does someone have it? Earlier they used to say it is, reason is not known, but now they are coming out with genetics. They are saying that the genetics associated with leiomyoma is going to be the MED12 gene mutation. MED12 gene mutation. Let me tell you something about MED12, which is very, very famous. Please note that not only in the female genital tract, but anything to do with females, not only females, FFF wala things. Everything that is to do with MED12 is going to be F for what is leiomyoma? Leiomyoma is a fibroid. Now, the fibroids show F MET12 mutation. After that, when you will be going on to the breast wala chapter, that is female again, you have fibroadenoma. Fibroadenoma can show you MET12 mutation. In the breast, you also have another tumor called Phyllodes tumor that can also show you MET12 gene mutation. So overall, I realized that all the female related FF wala things are going to show me MET12. The fibroid in the uterus, fibroadenoma and Phyllodes that is in the breast, that shows you MET12. So coming back, this was a leiomyoma fibroid, it shows you MET12. What is it going to show you microscopically? Very, very important. You can see the cells are somewhere going round and round. What is that feature known as? That is referred to as the whirling. This is referred to as the whirling of the cells. Whirling of the cells is seen. And what is the classical appearance of the nucleus that you see? Other than whirling, you see the nuclear appearance known as cigar nucleus. If you look at the nuclear, they are looking blunt like a cigar. They are going to be like a cigar. So remember, whenever the word cigar has been used, they are talking something about smooth muscle. It could be benign tumor of the smooth muscle. It could be malignant tumor of the smooth muscle also. Whenever the word cigar nuclei is asked, that's a previous year question. It is something to do with smooth muscle. That is my hint. Okay, now this is a regular leiomyoma, regular fibroid. What are the degenerations that can happen out here? So first and foremost, the common one is hyaline degeneration. Then calcium can deposit into it. So there's going to be calcific degeneration. But what is the picture that I'm seeing over here? Red degeneration, where there's the leiomyoma is going to get a nice beefy red color. Please note that this is usually associated with pregnant females. This is usually seen in pregnancy. Suddenly in pregnancy, the female is going to come to you with pain and fever. You will feel that there is some fetal complication that has happened. Maybe it's a miscarriage or an abortion, spontaneous abortion happening, or maybe some infection has happened. But actually it's a leiomyoma which has undergone a red degeneration. And that is the reason that she's coming up with pain and fever and all these infectious-like symptoms that she's coming with. So this is quite an important clinical history that you have to watch out for. That was about your leiomyoma. Sab kuch benign chal raha hai. Should we make it malignant? To make it malignant, I will have to use the word leiomyosarcoma. So they ask you, what is the most important criteria? When do you call it a cancer? The most important criteria is mitosis, and the cutoff for mitosis is more than 10 per 10 hypa field. Again, a previous year question. So when I have to convert benign into malignant, leiomyosarcoma, that time you're going to say more than 10 hypa field is the mitotic count that you have to know. Okay? Now, whether, as I said, is leiomyosarcoma also going to show you cigar nuclei? Yes. Anything to do with smooth muscle, be it a leiomyoma or a leiomyosarcoma or anything smooth muscle, cigar nuclei. Cigar is how I have taught you in the main videos also, that cigars, usually people who smoke say cigars are very smooth in comparison to cigarettes. They say cigars are smooth. That's a terminology that I've heard from them a lot. So cigars are always smooth. So cigar nuclei matlab something to do with a smooth muscle. Something to do with a smooth muscle that you see over here. So that was a quick review of this, and now we're going to start off with the next and the main topic, and those are the ovarian tumors. So now first I'll tell you the classification, and for each of them I've got a table. So what is the classification? Either the tumors arise from the surface of the ovary, so they are surface epithelial tumors, or they arise from the germ cells and the follicles, so germ cell tumors, or they arise from the sex cord stromal elements, so sex cord stromal tumors, or they are coming to the ovary, metastasis, that is Krukenberg tumor. So I've got 1, 2, 3, 4 tables, and the story of ovarian tumors will be done. Thoda sa congested table hai, but it's very good for your end day revision. Starting first and foremost with surface epithelial tumors, these are all the tumors that you have to know. Jaldi se go through their names. Serous tumors, mucinous tumors, Brenner tumor, clear cell tumor, endometrioid tumor. Can I concise them? Yes. Every surface epithelial tumor that you're going to talk about shall have a common tumor marker, and that is CA125. So at least one part of the table is sorted for me. CA125 is the common tumor marker for all the surface epithelial tumors. In this, the best way of learning it is, serous hai to make it SSS, mucinous hai to you will make the story MMM, Brenner hai to you will make the story BBB. That is how I have tried to make this table a little simpler. So if I ask you, which of them is going to present with a single watery cyst? Which of them is going to present with a single watery cyst? You will say serous will come with a single watery cyst. If I say which of them will have ciliated epithelium and psammoma bodies, so you will search a ciliated epithelium is also looking like S wala sound. So ciliated epithelium and psammoma bodies is also looking S wala sound. So all these SSS sounds have come together na. If I have a single cyst with a psammoma body and a ciliated epithelium, I am talking about serous ovarian tumors. And please remember, this tends to occur in both the ovaries. It tends to be bilateral, not always, but usually it tends to be bilateral. Talking about mucinous. Now if I ask you, mucinous में सब कुछ MMM, so which is multiloculated cyst, multiple cyst, so you will say अच्छा M मतलब it is multiloculated cyst. What kind of fluid? Obviously mucinous fluid. And what kind of epithelium? Again, common sense. The epithelium is gonna be the mucinous epithelium. There is no doubt about it because सब कुछ MMM चल रहा है. So if I'm seeing multiple cysts with mucinous fluid, with mucinous epithelium, I know it is mucinous ovarian tumor. Try to differentiate these. See, if you're seeing a single cyst, single watery cyst with this ciliated epithelium, and what if they mentioned psammoma bodies also? So single cyst with ciliated epithelium, what tumor or what ovarian tumor will you call it? Serous ovarian tumor. Versus if you see so many cysts, multiloculated, and they say this is filled with a lot of mucin, and they say this khali epithelium also has a lot of mucin. So when they're talking about all mucin wala stuff, you are going to call it mucinous ovarian tumors. How easy? Like I said, SSS, MMM. Now let's come to BBB. If they are talking about Brenner tumor, the microscopy will show you bladder epithelium. Bladder epithelium is what? Transitional epithelium. And there will be bean, matlab coffee bean nucleus is going to be noted. So bladder epithelium and coffee bean nuclei will be noted. So obviously this is the picture that you have to see. You can very well appreciate the nucleus over here has a line through it. So if the nucleus has a line through it, that's a coffee bean nucleus. Let me tell you here only, coffee bean. How many of you are coffee lovers? If you're coffee lovers, then you know that coffee to beans ko you first, what is the ideal way of making coffee? You take the beans, you grind the beans, you get a granular powder. So sabse pehle to granulosa cell tumor, granular powder, granulosa cell tumor. After you've got a granular powder, now you brew the coffee. Brew the coffee means there is Brenner tumor. So if you are a true coffee lover, you will know that coffee beans lo, pehle make it a granular powder, that is granulosa cell tumor. Then you brew the coffee, that is Brenner tumor. So that is coffee bean. So Brenner is going to be like bladder epithelium and coffee bean nucleus. Coming to the next, clear cell. Obviously it's going to have clear cell. No one will ask you that. They will just ask you one thing, which is the drug that has been associated with clear cell tumor. This is a recent question in FMG and NEET both. Diethylstilbestrol. Do you remember the story I had taught you way back in your neoplasia chapter, that diethylstilbestrol was a drug that was given to the mothers, pregnant mothers, and their daughters ended up having this tumors. These were basically said to be DES daughters. These were said to be DES daughters, that the pregnant mother was given diethylstilbestrol, but the daughter born was ended up with clear cell tumor. This drug is banned now. Coming to the next one and the last one, that is endometrioid. Obviously this endometrioid tumor is associated with endometriosis. So they ask you which of them is associated with endometriosis. Which of them is associated with endometriosis? Of course endometrioid ही होगा. And there are two genetics which I want you to learn, P10 and ARID1A. कुछ भी tough नहीं है. देखो P10 में तो N आता है, so obviously it is associated with endometrioid tumor. And ARID1A will always be to do with any kind of ovarian tumor, cervical tumor, endometrial tumor. You know why? Because RE is Nari. That's how I've learnt it. RE is Nari. So every Nari tumor is going to have this ARID mutation. So always remember P10 has N, so endometriosis, endometrioid, all the endometrial things are going to have it. And RE is Nari. So again, all the female tumors are going to have it. I hope that's okay. So if you learn SSS, MMM, BBB, over here for clear cell, you learn the DES daughters, and for endometrioid, you learn all NN Nari things. You are done with this. Tumor marker sabka CA 125, and the first category is a tick mark. I move on to the next category, that is going to be the germ cell tumors. Please note, I've got you a table for germ cell tumors also. The first one out of them is dysgerminoma, and now everything from here will be copy pasted. Matlab, in the testis, what is it going to be? In the testis, it is going to be seminoma. This entire table is going to be copy pasted as it is. All these tumors occur in the testis also. So firstly, dysgerminoma tends to have a cut potato appearance. It looks like an aloo. It looks like a cut potato. And microscopically, it's very famous for two things. One is a fried egg appearance and the other is lymphoplasmacytic inflammation. Very, very important. Let me show you. Have a look at this. Can you see these khali cells? These khali cells are all fried egg appearance. Fried egg appearance is seen, number one. And secondly, which is the lymphocyte and infiltrate that I'm seeing? This blue color dot. If you want, I can zoom into it. Can you see there is this blue color dot inflammation? So all of this blue color dot inflammation is the lymphoplasmacytic infiltrate that you are noticing over here. So please note, dysgerminoma means everything that I'm telling you out here for seminoma same. Seminoma may be cut potato appearance, fried egg appearance, and lymphoplasmacytic infiltrate will be seen. So basically, I'm giving you a nice morning English breakfast. I'm giving you mashed potatoes with fried egg and sprinkled it with little salt. That is lymphocytes and plasma cells. A nice morning English breakfast. So mashed potatoes with fried eggs and sprinkled it with lymphocytes and plasma cells. What are the tumor markers? Tumor markers are LDH and PLAP. Tumor markers are LDH and PLAP. Let's move on to the next one. Yolk sac tumor. Yolk sac reminds me of fetus, bachcha. So it's reminding me of endoderm. Yolk sac matlab endoderm, endodermal sinus tumor. What is it going to show me? The most characteristic body of this chapter. Schiller-Duval body or glomeruloid body. Firstly, why did you call it glomeruloid? Because it looks like a glomerulus. Glomerulus mein kya hai? Kidney chapter. Glomerulus has blood vessels in the center. Na? So this is going to have a blood vessel in the center. Please note, this is defined as a blood vessel. See how I've learnt it? If I tell you how theoretically I've learnt it. Blood vessel, tumor, space, tumor. Matlab blood vessel. Then aayenge tumor cells. Then there'll be a space. And then again there'll be tumor cells. So simple. Blood vessel, space, blood vessel, tumor, space, tumor. Otherwise, you can learn there's a blood vessel in the center. Glomerulus ki tarah, there's a blood vessel in the center. Then there are two rows of tumor cells and there is space between them. That's another way of learning. So dekh lo, there is a blood vessel in the center. Then there is one row of tumor cells that I see over here. There is another row of tumor cells that I see on the outside. And then there is a space in between them that I see over here. So center mein blood vessel hai. Then two rows of cells with a space in between them. That is a Schiller-Duval body or a glomeruloid body that you see in yolk sac tumor. And it is very famous for producing which? Very famous tumor marker, alpha fetoprotein and even alpha 1 antitrypsin, minor. But alpha fetoprotein, very, very important it produces. Coming to the next, choriocarcinoma. There's 1, 2, 3. That is how I learn it. I have to tell you one gross finding, one microscopic finding, one tumor marker. So instead of reading it from here, I will tell you directly with the help of images. When I'm dealing with the case of choriocarcinoma, it's very famous for having lots of blood and lots of necrosis. There are, dekho, red, sara blood ho raha hai. Choriocarcinoma is going to have a lot of blood and a lot of necrosis. Then I look at it under the microscope. I can see two types of cells. Some of the cells have 1 nucleus, chota 1 simple 1 nucleus it has. But then comes some cells which have too many nuclei. Look at this over here, look at this over here. There are lots of nuclei present. So what are the two types of cells? Firstly, we have something known as single wala cytotrophoblast and lots of nuclei, syncytium. What is syncytium? Syncytium means group. So these are multinucleated. Dekho, single cell matlab cytotrophoblast and multiple wala cell that you're seeing, that is going to be the syncytiotrophoblast. That is what you see in choriocarcinoma. And what is the tumor marker? Everyone knows it is beta HCG. So I think we are sorted when I come to this information. I'll write it for you. The tumor marker is beta HCG. Finally, coming to the last one, that is teratoma. What should I tell you about a teratoma? Everyone knows everything about a teratoma. I'll show you some pictures only directly. Please note, a teratoma is actually going to be of three types. Mature teratoma. Mature teratoma mainly means that it is totally benign. Iska koi bhi malignant potential nahi hai. Immature teratoma can definitely be malignant. So first and foremost, mature versus immature is benign versus malignant. But what they give you in the paper is this picture. This is the picture of a teratoma. How do I know it's a teratoma? Because I can see as soon as you start seeing tuft of hair, or maybe you could have seen some bone or some teeth or some other organ. So basically teratoma is having lots of different organs over here, right? Because if I ask you what is the definition of a teratoma, you will say minimum of 2 2 germ layers have to be present in order to call it a teratoma, है ना? So 2 germ layers have to be there, minimum. So now when I say fine, hair and all, teratoma to sorted, but what is this protrusion that you see over here? This is not a showpiece. I always say this is no showpiece. This is known as Rokitansky protuberance because this could be a foci of cancer. It's like a treasure hunt. It's a Pandora's box. Maybe cancer will come out of it, maybe not. No one can guess. So you will have to cut it. As a pathologist, whenever I get a specimen of the ovary and it's a teratoma, I cut the Rokitansky protuberance to see whether some cancer is hiding inside it or not. So Rokitansky protuberance may be one of the treasure hunts that we are looking at. Now coming to the next one, there's also something, abhi I told you that teratoma is supposed to have 2 germ layers, and now I'm saying no, there is a teratoma which has only 1 germ layer. Only 1 germ layer matlab 1 derm, not 2 ectoderm, mesoderm, endoderm, sab nahi, just 1 monodermal teratoma. And please remember, monodermal teratoma is struma ovary. Do you know what that means? You'll say, okay ma'am, only one thing is there. It doesn't have mixture of things. It doesn't have hair and teeth and nail and skin and everything. No, it just has one thing in the ovary. The ovary has thyroid. That's it. There are going to be thyroid follicles that are present in the ovary. And again, many people believe, yes ma'am, I can see the round thyroid and I can see the colloid also pink color wala. To bas ek showpiece ki tarah thyroid is sitting in the ovary. No, it's not a showpiece. This thyroid is functional. It is going to produce T3 and T4. It means that despite having this in the ovary, patient can have hyperthyroidism. Neck ka thyroid is normal. Nothing is problematic in the neck wala thyroid. But that ovary wala thyroid has started producing a lot of T3, T4. So this is a functional thyroid follicle that I'm talking about. That is a monodermal teratoma known as struma ovary, with which, guys, you will realize that we have finished the germ cell tumors. We are almost towards the end of the journey. I've done the germ cell tumors. Now I'm coming to the sex cord stromal tumors. Okay, so that's the third table that we have. Now, when I'm dealing with sex cord stromal tumors, jo jaldi wala hai, let me finish off in 2 minutes. There is something known as Sertoli-Leydig ka combination wala tumor, Sertoli and Leydig cell tumors. Then there is a pure Leydig wala tumor. So my rule is that wherever the word Leydig will come, whether it is a combination of Sertoli-Leydig or it is only and only Leydig, there is one thing that you see in Rehnke's crystalloids. Remember, Rehnke's crystalloids are going to be seen in the Leydig cells. So I want to show you what Rehnke's crystalloids look like. They are looking like these cylinders or rectangles. That is what you see in Leydig cells. Remember, Rehnke's crystalloids in Leydig cells, whether it is a pure Leydig cell tumor, whether it is a Sertoli-Leydig mixture, you don't care much about it. Leydig word dekha to mark Rehnke's crystalloids. So one is done. Next I go to, there is a tumor called fibroma. Fibroma matlab ऐसा लंबा fibrous cells. Long fibrous cells basically means spindle cells. And spindle cells are positive for what? Vimentin. There's another tumor called thecoma. Theca cells are all fatty cells. Theca cells are vacuolated. Fatty matlab what is the stain? Oil red O positive. So what did I tell you? Let me repeat all of this for you once again. When I'm talking about fibroma, I get to see fibrous wale spindle cells which are positive for vimentin. And when I mention the word thecoma, I get to see vacuolated cells which are oil red O positive. So this means that the fibrous part of the tumor is going to be white. And the theca part of the tumor is going to be yellow because usme fat hai. So sometimes they can occur together, and that is known as fibrothecoma. Please note, very important. In fact, if you read in your gynae, you must have seen fibromas. Very important. I'll tell you 2 things about fibromas which you'll get in gynae. Fibromas are number 1 associated with Gorlin syndrome. In fact, bilateral fibromas are associated. Dono ovaries mein hota in Gorlin syndrome. Whereas fibromas is associated with another syndrome known as the Meigs syndrome. What is it about Meigs syndrome? Jaldi se bata do. I had always told you, divide your body, so female body, into 3 parts and Meigs is done. What is Meigs? Kuch pelvis mein hoga, kuch abdomen mein hoga, kuch thorax mein hoga. So pelvis, abdomen and thorax, khatam. So what is that going to be? In the pelvis, you already know this female has fibromas in the ovary. In the abdomen, what is she going to have? She is going to have ascites. And in the thorax, what is she going to have? Right-sided hydrothorax. So simple, like I said, go from bottom and above. In every cavity, in every part of the body, you make something. In the pelvis, there is fibroma. Then abdomen pe aao, to abdomen mein there is something known as ascites. Then you come to the chest part, and that is going to have right-sided hydrothorax. So that makes Meigs syndrome. Fibromas are associated with Meigs syndrome. Coming to the last one, granulosa cell tumor, my favorite story. Every student who studied from any platform, any YouTube or anywhere knows that this is their favorite story also. Granulosa cell tumor is a granny. Granny means that post-menopausal female. In a post-menopausal granny, I don't expect a post-menopausal female to have estrogen, but she's having. This post-menopausal female is having a lot of estrogen, and do you know what is her age? Her age is 99. She's a 99-year-old granny, and suddenly her estrogen has gone very high. So estrogen has gone high, basically she's gone hormonal. If she's gone hormonal, you know what she's done? What mistake she has done in life? She has called her ex. She has given a phone call to the ex. Never look back at exes, but she has called back her ex, and she is showing you call exner bodies. And you know what she told her ex? Let's go out for a coffee date. So this is also going to show you the coffee bean nucleus. So imagine this is a 99-year-old granny. Suddenly her estrogen hormone levels went up. She ended up calling her ex, that is call exner bodies, and she asked her ex for a cup of coffee. And is that a good idea? Not at all. The first thing I said, zindagi mein kya nahi karna? Never ever call your ex. So basically this is inhibited. This is totally inhibited. So what is the tumor marker? The tumor marker is going to be inhibin. But tell me, someone who despite knowing all of this is still trying to act very clever and smart and chalu and still calling their exes and troubling them. Are they like innocent people or clever people? They are very clever people, as clever as a fox. So what is the mutation that you see? You see the FOXL2 mutation. Clever as a fox, FOXL2. So she is a, remember exam will have FOXP3, exam will have FOXL2, aise hoga. So she's a fox lady, clever as a fox lady. So remember FOXL2 is what you're going to mark over there. Okay? What did you see over here? Call exner body. These round bodies that you see with some pink material in the center is a call exner body. You can see one more over here also. These are call exner body, and I've told you they're going to show you the coffee bean nucleus. Can you see a line going through the nucleus? That is going to be, I'll show you some more. You see one over here, you see one over here. That line going through, that is the coffee bean appearance. So I hope this is one of your best stories also. A 99-year-old postmenopausal female with increased estrogen. She's a fox clever lady, so FOXL2, calling the ex or call exner bodies, coffee bean appearance, and this is inhibited, so tumor marker is inhibin. On that note, the last set of tumors that you need to know, guys, finally, sex cord stromal done. The last set is known as metastasis, and we all know that metastasis is referred to as the Krukenberg tumor. Metastasis to the ovary is Krukenberg tumor. So, for example, if this is the ovary, you will say that what are the tumors that can come to the ovary? Breast cancer can come to the ovary. Stomach cancer can come to the ovary. So breast cancer, stomach cancer, for that matter, even colonic cancer can come to the ovary, pancreatic, any cancer can come to the ovary. But the most common cancer coming to the ovary is the stomach. Repeating, the most common cancer that is coming to the ovary is the stomach, and this is known as Krukenberg tumor. I've already told you this in the previous segments also, that Krukenberg tumor shows you signet ring cells. I hope you all remember what was signet ring cells, that the nucleus was at the periphery. You could very well see that the nucleus is at the periphery like a ring. Why? Because they contain a lot of mucin. They contain a lot of mucin, as a result of which the nucleus has gone at the periphery. So this is what is the description of a signet ring. There are so many of them. This is a beautiful signet ring, another beautiful one. It's a very pretty picture cell, and that's your Krukenberg tumor. So my advice to all of you, when you'll do ovarian tumors, you'll do one box of surface that you have over here, one box of surface epithelial tumors, then you'll do one box of germ cell tumors, you'll do one box of your sex cord stromal tumors, and then finally you'll look at this one slide of Krukenberg tumor. So ovarian tumor to 15 minutes mein next time you're gonna revise it. Very, very simple. I hope you all got it. Done with the female genital tract. Now quickly open the video of male genital tract, copy paste all these tumors into the testicular tumors, and finish that also in 10 minutes.
Now let's begin with the male genital system. So starting with the male genital system, my first question to you is an MCQ format where a surgeon is suspecting a testicular carcinoma in a patient and asks the intern to send a sample for histopathology. What is the fluid in which the intern should send the sample to the pathologist? I know many of you are going to mark Bowen solution because you believe that anything to do with testicular cancer or anything to do with testis means it has to be sent in the Bowen solution. So please remember, whenever they are going to send a testicular sample, you have to ask the surgeon, why have you performed this biopsy? If that biopsy has been performed because they are suspecting a case of infertility, or have they performed it because they are suspecting some kind of a tumor? Because tumors in general are sent in the solution in which the entire pathology lab is full of. Whether it is a colon cancer, prostate cancer, thyroid cancer, brain cancer, or any other cancer on this planet, we always send it in 10% neutral buffered formalin. It is always sent in this solution. However, please remember, only if you are suspecting a case of infertility. Infertility may you are going to use the Bowen solution. In infertility, you should be using the Bowen solution. So do not use Bowen solution everywhere where you study testis. No, just read. Over here they ask you testicular cancer, means your answer should be 10% formalin. You are going to put it up in formalin. If they would have said that this is a biopsy done for testicular infertility query, then you would have sent in Bowen solution. And let me tell you, Bowen solution is a picric acid based solution. Okay, so this is what is the concept I wanted to start with. Now let's start off with the first disease of the testis, and that is known as cryptorchidism. Everyone understands cryptorchidism is the failure of the descent of the testis, and the most common site of arrest that you're going to have is going to be the inguinal canal. Inguinal canal is the most common site of arrest. So now, once the arrest happens, what is the person at a risk of? The patient is at a risk of testicular cancers. The patient is at a risk of testicular cancer. So you actually have to correct it. For correction, you have to do orchiopexy. So there has to be a corrective surgery that needs to be done, and that is going to be orchiopexy, and that needs to be done within 18 months, they say, right? Otherwise, there is a chance that the person might even end up having infertility. So the earlier the correction is done, the better. There are two chances, infertility and cancers. You don't want either of them to happen. So you have to correct it and bring that, you have to descend it down into the scrotal sac. What do you see microscopically? On microscopic examination, what will you notice? Tell me something. If the testis is lying above in the inguinal canal, will there be any spermatogenesis over there? No. So the spermatogenesis, of course, you will only see. You know what you're seeing over here? Ye jo cells and these are only and only the Sertoli cells. I am only seeing the Sertoli. I'm not seeing the spermatid, spermatogonia, spermatocyte, wo sab nahi hai, because spermatogenesis is not gonna occur. Second, the cells, if you see, they are surrounded by a very, very thick layer. So this means the basement membrane is becoming very thick and the spermatogenesis is not happening. Also, another thing that might be seen is Leydig cell hyperplasia. Leydig cells are what? They are outside. Ye jo wo testosterone producing wale hain, they might look more. I'm not saying they're always more in number. Hyperplasia doesn't mean always more in number. Because these cells are looking less, it might indirectly look more. So there might be a case of Leydig cell hyperplasia associated with it. Everyone's understood? So that is a quick review of cryptorchidism that you had to know. Now let's move on to the what you need to really know, that is testicular tumors. As I said, I'm not going to teach you most of the testicular tumors in detail because all of them are copy-paste of ovarian tumors. So if you've done the ovarian tumors, testicular is just a cakewalk now. Please note what are the genetics. Firstly, did I tell you cryptorchidism can cause testicular cancers? Go back to your genetics chapter. I have taught you Klinefelter is a male disorder that is also associated with testicular tumors. And this is a question you will be asked in surgery. Isochromosome 12p, very, very important question of surgery. Isochromosome, the only isochromosome associated with testicular tumors is I12p. Every cancer is going to have a precancer, you agree? So for testicular cancers, what is the precancerous condition that we have? So earlier they used to call it ITGCN, but now I want all of you to learn GCNIS. GCNIS matlab germ cell neoplasia in situ. See, if I've used the word in situ, that basically means that it's still pre-cancer stage mein na. So germ cell neoplasia in situ will be the pre-cancer from which all the cancers will occur except SST, that is spermatocytic seminoma and teratoma. They do not arise from this precursor lesion. So please remember, germ cell neoplasia in situ will give rise to all except the teratoma, and the spermatocytic seminoma. Now let me come down to the classification. I have divided the testicular tumors into germ cell tumors and non-germ cell tumors. Germ cell में of course one is going to be your seminoma only, and seminomatous tumors में क्या आएगा? There is going to be seminoma. Seminoma, everything I have taught you, because seminoma is the same as dysgerminoma in the ovary. So you have studied everything about seminoma. But there is a type of a seminoma which is known as spermatocytic seminoma. That is something that you have not studied, and that is what I want to tell you. So I'm only going to teach you the extra points. Ovary wala jo repeated points we are not doing, because we want to finish the syllabus in a rapid manner. But the different things I'm going to teach you. What is spermatocytic seminoma? Spermatocytic seminoma, because it's a very, very lengthy. Seminoma chota naam, seminoma small name. Spermatocytic seminoma, lengthy name. So this is going to occur after a very long age. That is, it is going to occur above 65. Very, very lengthy. So there are going to be lots of chromosomes. Everything is more. Age is also more. The size of the name is also more. The chromosome gain is also more. There is gain of chromosome 9 that happens. But overall, if you study, there is very slow growth. It is not going to spread. The prognosis is going to be very, very good. Okay, so repeating, it's a very, very lengthy name, very long name. It's going to be seen in very, very old people. It's going to be seen with a lot of gains. So gain in the name, gain in the age, gain in the chromosome. But overall, the prognosis is going to be good. And please remember, because you're talking about length, small size name, medium size name, large size name, microscopically it shows you 3 types of cells that are noted. There is going to be a small, a medium and large cells that are seen. Actually, they're defined as on the basis of the size. There are 3 sizes of cells seen: small cells, medium cells and large cells. That is what is spermatocytic seminoma. And is spermatocytic seminoma arising from the precursor? No. Remember, spermatocytic seminoma was an exception. It is not arising from the precursor. So repeating this once again. Seminoma chota naam, spermato, I write it as spermacytic because spermatocytic hota hai. That is the full name. So spermatocytic seminoma, long name, long age, long chromosomes, lengthy gained chromosomes. These were all the seminomatous tumors. What about the non-seminomatous tumors? I have already taught you. Non-seminomatous mein comes choriocarcinoma. We have studied it under the ovarian chapter. We have yolk sac tumor, again something that we have studied under the ovarian chapter. Then we have teratomas, finished under the ovarian chapter. We have one last, and that is embryonal carcinoma. That can also occur in the ovarian tumors. But remember, for embryonal carcinoma, there is only one question that comes in the paper, and that is CD30 positive. No, nothing else. Embryonal carcinoma, CD30 positive. That finishes off your germ cell tumors. Talking about your sex cord stromal tumors, please note, sex cord stromal tumors has Sertoli and Leydig cell tumors, which again you have finished off in your ovarian tumors. Sertoli cell tumors and Leydig cell tumors already covered. Again, nothing for me to note over here. Coming to the others. Others mein what you're going to have is going to be lymphoma. Lymphoma of the testis can definitely occur, and remember, when lymphoma occurs in testis, it is BBBB. What is BBBB? It is going to occur in Buddha people, that is above 60. It is usually involving both the testes, that is bilateral. The most common lymphoma is B wala lymphoma, DLBCL. B wala lymphoma is common, and the prognosis is bad. Repeating once again. It is going to occur in Buddha people, that is above 60. Both their testes will be involved, so it is bilateral. DLBCL, so B cell lymphoma occurs, and the prognosis is going to be very, very bad. That is what you need to know about testicular lymphoma. Sorted? We are done with the testicular tumors, and I think if you've done ovarian tumors, there is practically not much for me to teach you over here. Now we move on to the prostate cancer, and you know, in prostate cancer, I'm interested in 2 things, the markers and the scoring. So let's wrap it up. When I'm talking about the prostate cancer, see, there are 2 diseases that can occur in the prostate. Either the prostate can show you the presence of hyperplasia, or it can show you the presence of cancer. Please remember, hyperplasia occurs in the transitional zone of the prostate. HT, hyperplasia, is going to occur in the transitional zone of the prostate, whereas cancer occurs in the peripheral zone of the prostate. The periphery of the prostate is going to show you cancer. So cancer occurs in periphery, HTCP, whatever you want to learn. So I've learned it as HT, that hyperplasia occurs in the transitional zone. So periphery pe obviously there is going to be cancer. What are the markers? This is a very, very important thing which you studied way back in neoplasia chapter. Prostate specific antigen and prostate acid phosphatase. है ना? Prostate word only comes, prostate specific antigen and prostate acid phosphatase. They are markers. But the question is, what is the new marker that we have which has started coming in the paper? Please note NKX 3.1. Something which is tough to learn, I understand, but no option because it has come in the paper once before. NKX 3.1 is a new marker for prostate cancer. So what is it about prostate cancer that you have to know? In terms of clinical spread, remember prostate cancer is very famous for showing you the perineural invasion. Perineural. It's going to go and invade the nerves. Remember guys, there are 3 tumors in pathology which show you perineural invasion. The PAP tumors show you perineural invasion. One is going to be the prostate cancer in front of you. Another P is the pancreatic cancer. And the other one is going to be adenoid cystic carcinoma. The other one is going to be adenoid cystic. Repeating, prostate cancer, adenoid cystic carcinoma, pancreatic cancer. Especially adenoid cystic carcinoma, kahan ka? Salivary gland. Most famous question of adenoid cystic carcinoma in the salivary gland is that it's very painful. Why is it painful? Because it goes into the nerves. Anything going to the nerve will be painful. So what are the tumors that show you perineural invasion? Prostate cancer, adenoid cystic and pancreatic cancer. Done? Now the last thing that you have to know is Gleason. You know that Gleason scoring is something that is done for prostate cancer. So pehle, I know all of you don't know the meaning of this pattern, scoring, grading. So kaise yaad karenge? Before I go into all that mathematics, what did I write? There is a pattern, then there is a scoring, and then there is a grading. So basically you have to learn it as my name. I made a selfish mnemonic. Preeti Sharma Group. Preeti Sharma Group. You are all a part of my group, study group. So Preeti Sharma Group is what you will learn. Means in the exam, when you get Gleason, you will say, sabse pehle I will find out the pattern. After that, I'm going to find out the score. And after that, I'm going to find out the grade. So I'm going to do a pattern, then scoring, then grading. So that is Preeti Sharma Group is how I learnt it. Let me start. First, I'll teach you all the patterns. Then I'll teach you how to take out the score. And then I'll teach you how to take out the grade. Okay? Patterns. How many patterns do we have? 1, 2, 5. Bahut simple. Trust me, very simple. Prostate cancer, if don't read all this, okay? Just listen to pattern number 1, 2 and 3. Matlab, if the glands are back to back, pattern 1. If they are little away from each other, pattern 2. If they are very much away from each other, pattern 3. If they are back to back glands, pattern 1. If they are little away from each other, pattern 2. And if they are highly far away from each other, pattern 3. Easy na? So you will remember 1, then 2 and then 3. Sorted. Coming to pattern number 4, there are 2 patterns that are going to come under it. What are the 2 patterns? There is something known as cribriform pattern. Cribriform pattern. Iska photo I will show you in a while. And the other one is known as the hypernephroid pattern. The other one is known as hypernephroid pattern. So now how do I learn it? That achha, these are in pattern number 4. Very simple. From today onwards, you will learn it as cribriform pattern. From today onwards, you learn it as cribriform pattern, and you can also learn it as hypernephroid pattern. Hypernephroid pattern. So repeating, there is a cribriform pattern and a hypernephroid pattern. So 4 number is coming. This means this is belonging to pattern 4. And what is it about cribriform? What do you mean by cribriform? So dekho, cribriform means channi, sieve. That is what is cribriform. It will have holes like this. Everyone seen a sieve or a channi, na? Channi with which you sieve out the tea every morning. So yes, you will see these small holes. When you see small holes, that is cribriform, matlab pattern number 4. Similarly, hypernephroid is pattern number 4. Coming to the 5th and the last one. You will, abhi tak to you were seeing round glands. Now you will see separate cells. In pattern number 5, you will see single cells or you will see death. Means comedo, neck crosses. Neck crosses means death, and it's very bad. That's why I've kept it in the end. Either you'll see single dot cell, or you'll see comedonecrosis. Have a look at this comedonecrosis. As soon as the word necrosis comes, you will say, oh, this is the worst pattern. This is pattern 5. What is comedonecrosis? Can you see? This is a big duct or a gland, and I see a lot of dead material inside it. I see a lot of necrosis inside it. So that is going to be comedonecrosis pattern. So repeating once again, I have calculated how many patterns. So simple. If you had to do 1, 2, 3, 4 and 5. 1 में क्या था? The glands were back to back. 2 में they were a little away. 3 में they were very much away. 4 में you had 4 cribriform and hypernephroid. 5 में you had single cells, or you had the death, necrosis. Patterns are done, because now my concept is that if you've done with the patterns, you should be able to do the scoring. So a pattern I'm not interested in. Let me go on to the scoring aspect. So what are you going to do in the paper? You guys are going to first and foremost write this कि examiner ने क्या pattern दिया. What all patterns have been given by the examiner? Has the examiner given 2 patterns? Then I add the 2. If the examiner has given only 1 pattern, then I'm gonna double it up. If the examiner has given 3 patterns, then is the confusion. So what do I mean by that? ध्यान से सुनना. This is where most students lose track, okay? When I say predominant, what is the most of the slide made up of? Predominant pattern is going to be pattern number 1. Okay, primary pattern, primary matlab predominant, and then there is a minor pattern which becomes secondary. So if I say I'm looking at a slide like this, and in that slide I could see majority, 80% of the tumor is made up of cribriform and 20% of the tumor is made up of comedonecrosis. So you'll say, ma'am, 80% of the tumor is made up of cribriform, matlab cribriform is the primary pattern. What is cribriform? 4M. Primary pattern is 4. And 20% of the tumor is made up of comedonecrosis. Comedonecrosis is pattern 5. This means the secondary pattern is going to be 5. Bas kya karoge? You are going to add it. If you have 2 patterns given, you are just going to add it. So what is your score going to be? Your score shall be 9. So this life becomes so simple. If you have 2 patterns, add the 2 patterns. If I have only 1 pattern, I say this entire slide is only showing me cribriform, nothing else, only cribriform. You'll say, acha ma'am, only 4th cribriform dikh raha hai. What should I add it with? You can't add it with anything else. Double it up. If you see only 1 pattern, you are going to double it up. This means if the entire slide was showing 4th pattern, what would your score be? 4 plus 4 means your score becomes 8. The problem arises when there are 3 patterns. They say 80% कुछ दिख रहा है, then 15% कुछ और दिख रहा है, 5% कुछ और दिख रहा है. So when there are 3 patterns, that is when I have a confusion. So remember, primary तो you will have to consider. Out of secondary and tertiary, whichever is the higher grade or the higher pattern, you are gonna pick that up. So I'll give you a hint for that also. If they say, now in the same slide, I'm gonna show you one more thing. If they say that I have divided this slide into that 80%, look at this carefully, 80% of the tumor is gonna be made up of cribriform pattern, matlab pattern number 4. Then 15% of the cell is made up of comedonecrosis. You will say, okay, comedonecrosis matlab pattern number 5. Then 5% of the cell has back-to-back glands. Back-to-back matlab pattern number 1. So now I have 3 patterns. I have pattern number primary, which I have to take. Out of these 2, whichever is the higher pattern, I'll take that. So 5 is the higher number, so I'll add 4 with 5. I'll add 4 with 5. Whichever out of these 2 is the higher pattern, I will select that. That is the concept. So I will now repeat this concept once again for you. बहुत simple है. If you have 2 patterns given, add them up. If you have 1 pattern given, double it up. If you have 3 patterns given, pick up the first one, and out of the 2, pick up the higher one, and you get your score. But once you've got your score, pattern ho gaya, scoring ho gaya, what is the end result? You have to find out the grade. Any score up till or equal to 6 makes it grade 1. However you got the 6, 2 plus 3 5 आया, या फिर 3 plus 3 6 आया, या फिर 4 plus 2 था, howsoever you got anything up till 6 means that is grade 1. 7. The lucky number 7 is not so lucky here, because how did you get 7 makes a difference. Did you get 3 plus 4 7 or 4 plus 3 7? If you tell this to some non-medico, na, he think you've lost it, because 3 plus 4 and 4 plus 3 is the same. 7 hi to hai, but we know the difference na. In 3 plus 4, the primary predominant pattern was 3, and in 4 plus 3, the predominant pattern was 4. So it's different, hai na? That is changing. So if 3 plus 4 is 7, then I take it as grade 2. And if 4 plus 3 is 7, I grade it as grade 3. Finally, 8. If score is 8, then it is grade 4. And if score is 9 or 10, it is grade 5. Almost half-half chal raha hai. Dekho, anything up till 6 is grade 1. Then if the score was 8, to uska half is 4. So the grade becomes 4. Anything 9 or 10 score, to uska half is 5. So the grade is 5. The only problem is between these grade 2 and grade 3, because 7 ka score is coming. So if it is a 3 plus 4 7, it is grade 2. And if it is a 4 plus 3 7, it is a grade 3. And that is what you have for the Gleason scoring. Are you feeling a little confident? So I'll revise it for you. First you analyze the pattern, then you add them and you get a score, and you finally get a grade. Don't be in a hurry in the paper. I want you to solve these 2 questions before we end. Tell me, there's a 69-year-old male who's on rectal examination found a hard irregular nodule in the prostate and the PSA levels are elevated. The truss-guided biopsy shows you tumor cells without any glandular formation. Dekho, they have started with that Gleason. So as soon as this question comes, I will write Preeti Sharma group. I will write PSG in the exam. Okay? Remember me when Gleason comes. So patterns mein you will say there will be a primary pattern, there will be a secondary pattern. Primary mein likha cells without any gland, without matlab single cells. What is single cell? Pattern number 5. 10% of the tumor also shows cribriform pattern. What is cribriform? Pattern number 4. Score क्या आएगा? 2 ही चीजें हैं. Add them up. Score comes out to be 9. When the score is 9 on 10, what is the grade? The grade comes out to be 5. How simple. Practice. One more question. Look at this. There is a prostate cancer showing adenocarcinoma predominantly in, this has started. PSG likh lo. Predominantly in cribriform pattern. So there is a primary pattern that they have given, which is cribriform, followed by crowded pattern but separate glands. क्या लिखा है? Crowded pattern but separate. मतलब this was 1, separate matlab 2. So there is a secondary pattern written which is looking like 2. Now coming to the next. And a minor component of 5% of single cell infiltration. This means there is a tertiary pattern also. Minor component and single cell. Single cell means pattern number 5. Now guys, I have been given 3 things. What do I add? Primary, so you will have to take. Out of these 2, you're going to take the higher number. Higher number is 5. So you shall be taking 5 over here. What is the total? The score becomes 9. 9 ka score kya hota hai? It is going to be a grade 4. This is one of the toughest questions and it came in the previous year AIIMS exams. That is why I wanted to discuss this with you. It has 3 patterns. Remember, when there are 3 patterns, you pick the primary one, so you have to take, and then out of the 2, you take the higher number. So whenever you get a question on Gleason, PSG, follow that order, you will always be on track. So with that, we wrap up our male genital system rapid review. I hope you guys have quickly revised the testicular and the prostate cancer.